going to share the screen. Let me see here we go. There we go. Yep. Now today it's behaving. I don't want to say that too loud because, hi Cheska. I don't want to jinx us too much. Okay, well. No. You know, will you come put him in his crate? Elena, you're still on Zoom. I just don't want you to say anything you don't want anybody else to hear.
Oh, that was it.
When I called my husband yesterday, I was like, you are, or was it yesterday? Yeah. I'm on Zoom and I'm in a Zoom meeting with the students. Oh, goodness. Oh, we're almost there. What time is it? Yeah, one more minute. I may not have a whole lot of people here today because this is the third day in a row, but they can listen to it on D2L. I apologize for not getting the D2L up until later last night because I am so afraid of saving that on my own that I'm going to lose it. And I'll wait for my husband to come home, and then he comes home and then he wants to do something. And then, you know, I was also doing something. I was working on the math test, and by that time it was, I think, 7:30 or 8 o'clock. So, but it was put up in the evening. It just wasn't put up right away. Okay, it's 9 o'clock. So we're going to start. We're going to start with complications from the chest tube. And one of the complications is chest tube malposition, and that's the most common complication. And what you have to do is make sure you observe for titling in the water seal chamber. This will all make better sense once you actually get your hands on a chest tube, which you will when we do lab next week. I'm going to put it in there with Professor Nally, and she can help you with that. Listening for breath sounds over lung fields, measuring the amount of fluid drainage. We went over that yesterday when I put it up on the board. So re-expansion pulmonary edema can occur after rapid expansion of a collapsed lung in patients with pneumothorax or evacuation of large volumes of pleural fluid greater than 1 liter. The body just responds in that way. There's too much of a change in pressures, and the body responds with, you know, the lungs go into pulmonary edema. And it can actually happen even if it's not a rapid expansion. It's just a complication that can happen. You're not going to see this anymore on any tests or anything, but if you go into critical care, just, you know, be aware that it could happen. And it doesn't happen, you know, it can happen like you take the chest tube out maybe 48 hours later, you know, up to 48 hours later it can happen. So also infection at the skin site is a concern because it will, you know, go into, enter into the lungs. So we have to be careful with that. Pneumonia from not taking deep breaths and not using the incentive spirometer. This is painful. You know, it's painful going in. It's sore when it's there because, you know, when they move around, it's like, you know, it can wiggle a little bit. So, but we have to encourage them to use that incentive spirometer. It's very important. We do not want them to get pneumonia with a chest tube in. Okay, crepitus. That's like the Rice Krispies feel that they get under the skin. Okay, and what does that mean? That means that air has leaked into the subcutaneous tissue. And the doctor will want to know that, and will want to look at it, and you may need to readjust the chest tube. Okay. Okay. Continuous bubbling in the water sealed chamber indicates indicates an air leak at the insertion site or in the thoracic cavity. Okay. So, oh, doesn't want to advance. Wait a minute. Let me fix this. Okay. So this part is important. You're going to see some of this on the exams. Chest tube removal. It's removed when the lung has re-expanded and drainage has ceased. And that's what I was talking about yesterday, on why it is so important to mark the times, you know, when you see the drainage, because then the physician can look and say, oh, well, they're really slowing down. We need to keep an eye on this. We may need to take this chest tube out today or tomorrow. The tube, this is how it's removed. Cutting the sutures, applying sterile petroleum jelly gauze, dressing, having the patient, okay, you have the tube in, you cut the sutures, the doc's gonna do this, or the nurse practitioner. Put your hand over the site, and then you're gonna, with the petroleum jelly dressing there, and then you're gonna have the patient take a deep breath, exhale, and bear down, and that's when you remove the tube. You don't want to be inhaling, you don't want the patient to inhale at that time, because they will inhale all of the positive air pressure, and we don't want positive air pressure in here. The thoracic cavity is a negative pressure area, okay? That's why we're doing it that way. Okay. The site is covered with an airtight dressing, and the pleural seals itself within several days. Chest x-ray is done to evaluate for pneumothorax or accumulation of fluids, and the patient should be observed for any kind of respiratory distress. If you do see that, you need to notify the physician right away. You know, they could develop, you know, the pneumothorax. Maybe the fluid is back again, you know, that's filling the, maybe they might have a embolus. So you just want to make sure that you keep up on top of that. Okay. So pleurodesis, we talked about this earlier, but we're going to talk about it again. Creation of adhesions between the parietal and the visceral pleura, okay, to prevent recurrent pneumothorax. And it's an installation of a chemical agent, doxycycline, to cause inflammation and scarring. That's, they want to cause that so that it roughens that area up. Surgical creation of adhesions or partly excised parietal pleura, because they don't want it to be slippery in there. That's what causes, and it's not for everybody. You know, it's just certain people have this. And what they need to do is to make it rough in there, so that when the lungs expand, they don't, you know, slip right back without, you know, oxygenating the patient. Okay. All right. So what is acute respiratory failure? You'll see that represented as ARF. The description is a consequence of severe respiratory dysfunction. Lungs are unable to oxygenate blood and remove carbon dioxide. So the definition in terms of arterial blood gas values, arterial oxygen level, and you will see that represented as PO2 or PCO2, or well, it's capital P, small a, and CO2. Okay, that's how I put it on the chart, because when we're doing ABGs, because it's easier for you to understand and follow. Arterial carbon dioxide, oh wait a minute, arterial oxygen, oh wait a minute, I got ahead of myself. Arterial oxygen level is PO2, and it's less than 50 to 60 milligrams of mercury. Arterial carbon dioxide, PCO2, greater than 50, okay? And we're gonna go over all that, so don't get confused. I shouldn't even put that there. Dyspnea interventions, what do we give them when they're short of breath? Right away, we can't reach for the oxygen, right? Oxygen therapy. Position of comfort, which is usually sitting up. relaxation, diversion, and guided imagery. The relaxation I go with. The diversion and guided imagery, I'm not sure. It's never worked for me. Trying to, you know, somebody who can't breathe is not going to be diverted from that. And you're not going to say, okay, let's take some deep breaths and think about, you know, no, they're not going to listen to you. They are scared. They can't breathe. We're going to try some energy conserving measures, like when we go in to bathe them, make sure that we also listen to their back for lung sounds. And I'm trying to think of what else. Try and do things in, you know, like group them together, so you're not going in and out constantly, and they're having to, you know, use a lot of energy. And drugs. Give them, if they're having trouble breathing because of pulmonary edema, probably going to give them some Lasix. Lasix doesn't work, you give them Bumex. But, you know, that's one of the things we can do. All right. Adult respiratory distress syndrome, or ARDS. Now, you've probably heard a lot of this being discussed in the media, in you know, any kind of medical sites that you've been on because of COVID. COVID first came out, I was sitting there and I said to my husband, boy, this sounds like ARDS. And he's like, well, yeah, according to what you said, yeah. But then we thought, then they said, no, it's not ARDS. And now we're back to the point where it's ARDS-like. And you'll see why. And you can see this right here. Look at this chest x-ray. It's whited out. There's a lot of white there. With chest x-rays, just to, you know, so that you know, the chest x-ray, the lungs should be dark, okay? Any kind of whited out part there is going to be, it's a problem, you know, whether it's a fluid, whether it's a pneumo. Now, the middle part there is, let me use my pointer, is of course the heart. So that's okay to look like that, all right? Where are you? Here. Okay.
Tina,
Yeah.
you're not recording.
Oh, I said I was. I thought
I see that she's recording.
Oh, okay.
The recording on the top.
yeah,
Oh, okay, I didn't see it. Sorry.
that's okay. Okay. Client with acute respiratory distress syndrome. It's characterized, and this is very important. This is like the most important distinguisher. So, and we'll get to that. Characterized by non-cardiac pulmonary edema and progressive refractory hypoxemia. Refractory means that it just keeps coming back, okay? So the alveoli fill with fluid, resulting in severe dyspnea, hypoxia refractory to supplemental oxygen. Okay, so you have these little, board here. Can you see me? Yeah. Okay, so you have these little alveoli, and they're in the lung. Can you see that? Probably not, because of the, wait a minute, let me dim this a little. Is that better? Maybe if I make the circles bigger. Okay. Okay. See that? Kind of, sort of.
Yeah.
Normally, this would all be air exchange. What happens is you get fluid in these alveoli, like I was talking about yesterday. So that cuts down on the amount of air that can be exchanged, okay? And it's a severe form of respiratory failure. And here's the thing, it has a mortality rate of 50%, just with the ARDS. Now, if you have both gram-negative septic shock and ARDS, they have a mortality rate of 70 to 90%. That's very high. Okay. Incidence in the US is estimated to be more than 150,000 cases annually. And my guess is it has gone up exponentially in the last few months. Okay, let's go on. So what are the common causes of ARDS? direct lung injury, aspiration of gastric contents, viral bacterial pneumonia, chest trauma, embolism, fat, air, or amniotic fluid, inhalation of toxic substances, near drowning, oxygen toxicity, radiation pneumonitis. Indirect lung injury would be sepsis, especially gram-negative infections, and I talked about that. Severe massive trauma, acute pancreatitis, anaphylaxis, cardiopulmonary bypass, DIC, disseminated intravascular coagulation, multiple blood transfusions, narcotic drug overdose, heroin, non-pulmonary systemic diseases, severe head injury, and shock states. So we know what causes, what can cause this, but we don't know why. Okay, they're still working on that. So, acute direct lung injuries resulting from an unregulated systemic inflammatory response, which damages the alveolar capillary membrane. Pardon me. Exact cause for damage to the alveolar capillary membrane is unknown. Increased interstitial pressure and damage to the alveolar membrane allow fluid to enter the alveoli, which dilutes and deactivates the surfactant. What does the surfactant do in the alveoli? It allows it to expand, right, and take the oxygen in. If it cannot expand and it becomes very stiff, say, this is how it has to get in order to be oxygenated properly, right? If it makes it very stiff, okay, it's not going to expand. Plus you have the fluid in the bottom here. So it's, like cut in half or however, 2/3. And what's little that is left can still not expand properly. So does that make sense?
Yes.
Yes. Okay. Atelectasis occurs, lungs become less compliant, and gas exchange is impaired. Haline membrane forms and lungs become fibrotic and stiff. I don't know, maybe Ange remembers this. When the Kennedys had John Kennedy and his wife, Jackie had a baby boy, and he had haline membrane disease because he was so premature. He died because at the time they did not have artificial surfactant. They didn't have that until 1970. I don't think it was 79. I think it might have been 1980. So that's when they can give the babies or whoever, they can give them surfactant, and it helps to make the lungs respond and be able to take the oxygen in. So these patients who have the stiff lungs need higher airway pressures. The way in which we achieve that is to put them on a mechanical ventilator and put them on something called PEEP, and that's positive end expiratory pressure. And 5 to 10, CMs, but I know that the COVID patients, they're going up to as high as 20, which is very high. All right. Reduced lung compliance greatly increases the work of breathing. Hypoxemia becomes refractory and resistant to improvement even with supplemental oxygen. You can put oxygen on these patients and it doesn't do any good. Metabolic acidosis occurs, leading to multiple organ system dysfunction. So you can't take the oxygen in through your lungs, your tissues are not being oxygenated, your organs are not being oxygenated, and they start to fail also. Ours develops about 24 to 48 hours post initial insult. That's how we were able to figure out what causes it, but we still don't know why. And why does it happen to some people and not to others? Okay. All right. So manifestations: hypoxemia, Remember we said refractory hypoxemia. Dyspnea and neurologic symptoms. These patients are restless. They're apprehensive. Their judgment is not good. They, at first they may try to get out of bed. They're going to leave the hospital. Motor impairment. And then once, it progresses, they would have motor impairment. Early manifestations, dyspnea, tachypnea, anxiety. And we know any hypoxic patients, they display these signs and symptoms. Client increases respiratory rate and uses their accessory muscles. They're breathing. They can't get the air in. They're trying to get it in. Client becomes cyanotic and client develops crackles. That right there is very important. So star it, highlight it, whatever you need to do with it to remind you to study it. Continued respiratory failure results in mental confusion. Okay? So, ABG, hypoxemia with PO2 is less than 60 millimeters of mercury and respiratory acidosis. They have respiratory acidosis at first. Okay? But then once it progresses throughout the tissues, you're going to have metabolic acidosis, but that happens further down the line, okay? Chest x-ray is another diagnostic test. Pulmonary function tests, we talked about those yesterday. Pulmonary artery pressures, that's a SWAN. I don't know if anybody's heard what they are, the Swan Ganz catheter. That will also be in the lab next week. Normal pressure in ARDS. This is a thing. With pulmonary artery pressures with the Swan Ganz catheter, if someone has pulmonary edema, the numbers increase. It tells us that there is fluid in the lungs, okay? With ARDS, it doesn't increase. It's a normal pressure. There's still fluid in the lungs. The lungs are still stiff, but it's just telling us that it's normal. Normal pressures in the lungs. And this is what differentiates ARDS from pulmonary edema. That's also very important, okay?
What differentiate the pulmonary artery pressure?
Yes, the normal pressure in ARDS with the pulmonary artery pressure differentiates it from pulmonary edema. With pulmonary edema, the pressures go up. With ARDS, they're normal. Okay?
Okay.
So, clinical progression, it varies among patients. Like I said, one patient can have it, another patient doesn't. They've had the same problem. They might have both had near drowning. One gets it, the other one doesn't. That's the same thing with the clinical progression. One person may progress, another person may get better. So, some survive the acute phase and complete their recovery in a few days. And that also depends on their age, if they had any kind of chronic conditions. All of these play into, the clinical progression. Others do not survive, especially those who require long-term mechanical ventilation. Several factors are important in determining the course of ARDS: nature of the initial injury, extent and severity of coexisting diseases, and pulmonary complications. Okay. So, clinical manifestations often insidious. For the first 1 to 2 days, the patient will not exhibit or experience any respiratory symptoms. They're fine. They look fine. Chest auscultation may be normal, or they may feel fine, scattered crackles. Okay. ABGs usually indicate mild hypoxemia and respiratory alkalosis caused by hyperventilation. Trying to get that air in. It's starting, the ARDS is starting, and they're trying to get that air in that their body needs. Chest x-ray may be normal or may exhibit evidence of minimal scattered interstitial infiltrates. Pardon me. Edema may not show on the x-ray until there is a 30% increase in the fluid content in the lungs. Okay, it's almost like, like a stealth disease. one minute you're fine and the next minute you're not, but it's been going on for, you know, however long a period of time. And then sometimes it doesn't even exhibit anything, you know, anything that we're used to with dealing with pulmonary edema. So as it progresses, symptoms worsen because of the increased fluid accumulation and diseased lung compliance. Respiratory discomfort becomes evident as the work of breathing increases. You have tachypnea and intercostal and suprasternal retractions may be present. Now, we talked about those yesterday, and we know that that's dangerous, okay? They're getting seriously ill. Increases to profound respiratory distress. Tachycardia, diaphoresis, changes in sensorium, it decreased mentation because they're not getting the oxygen to their brain. Cyanosis and pallor may be present. Chest auscultation may reveal scattered to diffuse crackles and bronchi. Okay. Chest x-ray demonstrates diffuse and extensive bilateral interstitial and alveolar infiltrates. That's when, you know, we have the fluid in the lungs and those alveoli are getting very stiff and these patients just cannot get the oxygen in that they need. So this is the precise criteria to define ARDS, and you will want to study this. Refractory hypopoxemia, chest x-ray with new bilateral interstitial or alveolar infiltrates, PAWP, and that is pulmonary artery wedge pressure. That is a SWAN. Same thing, that's part of SWAN readings, okay? Of 18 millimeters or less with no evidence of heart failure. We've got increased pressures in the lungs, but there's no evidence of heart failure, okay? Predisposition conditions for ARDS within 48 hours of clinical manifestation. So all those direct injury and indirect injuries, if they have, you know, one of those, that's going to tell you, it's going to move you towards the diagnosis of ARDS. Not you, but your team. You're part of the team. Okay, treatment. Intubation and mechanical ventilation with oxygen set to maintain PO2 greater than 60 and oxygen saturation is 90%. That's what we want to see. Prone positioning, laying them on their stomach, okay? That's really tricky when they have, when they're ventilated or on a mechanical vent, they have ET tube in, because you turn their head sideways, and if they are a little bit awake, they try and rub that tube out. So, you know, the best thing to do is to, you know, give them paralytic and put them on Versed, and that way we can keep that tube in and stop them from trying to rub it out. Now, these patients should also be on, I call them rescue beds. They're special beds. They're very expensive, even to rent, but they're laying on their stomach, or a patient who's laying on their back. And some of you may have seen these. Ange might have seen them, or whoever works, you know, in the hospital. But they do chest PT. They turn the patient. You can set, you know, how often you want them to turn. They're softer. They prevent breakdown, or they, you know, they may not prevent it totally, but it's better than laying on a hard surface. So that's what we use in critical care. Careful fluid balance. We don't want to give them too much fluid because we don't want more of it going into the lungs. And you're going to treat the underlying problem, okay? If they have gram-negative sepsis, we're going to give them an antibiotic, or antibiotics, I should say, and supportive treatment, steroids. We want those lungs to start to heal, okay? Give them surfactant to help with moving the, being able to move the alveoli, make them not so stiff, okay? All right, so you also would give them medications to promote bronchodilation It's really interesting when you're trying to give them a neb treatment, or the respiratory therapist is, they're on their stomach. A lot of them will they won't be able to turn their head all the way, but their head will be like halfway down into the mattress, and you're trying to get their head turned back without hurting them, to put the mask on. So I said corticosteroids to reduce airway edema, and antibiotics to treat the infection. I had myself on this. So what's a good nursing diagnosis for these patients? Impaired gas exchange, decreased cardiac output, and dysfunctional ventilator weaning response. They are very difficult to wean off of the vent, okay, because their lungs have had major assault. Not only and after, during the whole issue, the tissues have been deprived of oxygen, so they are trying to recover also. And it's very, very difficult to wean them, okay? So nursing planning, overall goal for the patient with ARDS are PaO2 of at least 60 millimeters of mercury, and adequate lung ventilation to maintain normal pH. After recovery, the patient will have an SaO2 greater or baseline values on room air. The SaO2 is greater than 90%. And that's, SaO2 is what we do with the O2 stat monitor. Thank you. Patent airway and clear lungs on auscultation. Okay, so collaborative therapy. Respiratory therapy. This is a team approach. No one person is more important than the other. But nurses do spend the most time with the patients. Now, I'm not saying that we're more important. I'm just saying that we're a very important part of the team. Respiratory therapy, oxygen administration, prone positioning. They will help you prone them, and this is part of the respiratory therapy. Lateral rotation therapy, and I don't know if you've ever seen the proning stretchers, where they put the patient on the stretcher and they are able to turn them so they're on their stomach, proning. And then if you say you want to, I don't know, you need to change something, or you need to put an IV in, you can turn them back onto their back, and then do what you need to do, and then turn them again and put them on proning. Not too many places have these. So in order to prone a patient, it takes at least 4 to 5 people. And that's for somebody who's I would say average weight. If you have a very large person, it will take more people, okay? Mechanical ventilation with PEEP. PEEP is great when it, positive end expiratory pressure is great. But you have to be really careful because, and we'll go over this later, but with PEEP, what happens is it expands the alveoli, forces the air into there, the oxygen, and in that process, it is putting more pressure in the thoracic cavity. And you have your heart there, and it's putting more pressure on the heart, and it can cause the blood pressure to drop. So you have to be really careful with that. And the other part of that is, what was I going to say? Oh, it can also cause pneumothorax. Okay, it all depends. You got to be really careful. You start out with the lowest possible PEEP that you can, get away with, trying to accomplish your goals of oxygenating the patient, and then the doctor and the respiratory therapist may have to increase it. Okay? Supportive therapy, identification and treatment of the underlying cause, hemodynamic monitoring, which is your Swan-Ganz catheter that I just talked about, an ART line, okay? Those are hemodynamic. CVP, you have triple lumen catheter in, and CVP reading. Now with a Swan, you can get a CVP off of that. They don't always Swan these patients. It used to be they did for all of them, but swans have fallen out of favor for some, at some facilities because there's an increase in infections because it's an invasive process and it stays there. And if the balloon pops, it can cause some problems in the lungs, and it has. If people overextend the balloon when they're doing a wedge pressure, it can cause some trauma in the lungs. So when next Wednesday, I'll show you the balloon on the swan. It's this teeny tiny little balloon, but you figure it's going in your arteries, you know, your pulmonary artery. Okay, so supportive therapy, identification and treatment of the underlying cause, hemodynamic monitoring, inotropic and vasopressor medications, dopamine and dobutamine are used for these patients. And I want you to study those and see why we would use those. You know, why would you use dopamine? Okay. What did I say about the thoracic pressure? What does it do to the heart? Come on, guys, I just said it.
Isn't it like squeeze it?
It
Or
squeezes. And what does it do to the blood pressure?
it makes it go down.
Makes it go down. Dopamine, you start out at the lowest dose, which is called a renal dose. And you know, it's usually 2 milligrams per, 2 micrograms per kilogram per minute. And it will raise the pressure. But if it doesn't, you have to go up on it. You know, and that's, you know, we're trying to get that blood pressure to at least be able to perfuse the tissues. Okay. Dobutamine, if the heart's not working properly, if we're having problems with the heart, with the fluid backing up and it's taxing the heart, we're using the dopamine. We also could use dobutamine. Dobutamine we use after dopamine. Dopamine's not working well, we put the dobutamine in if the heart is having problems responding. And you're going to have a bunch of other, I mean, you're going to have antibiotics hanging in there. You're going to have regular IV fluids. You may have a cardiac drug in there. So when I said yesterday, if you're in ICU, you're going to be hanging medications all day. Yeah. Because people say, well, why do they only get 2 patients? Well, trust me, there are days when I didn't get to go to the bathroom and I didn't get to eat lunch. I carried a granola bars in my pocket, and I would wash my hands real good, walk over on the side, take a bite out of my granola bar, you know, so because we can't function on the floor if we're not properly, we don't have anything to eat because our sugar, you know, our blood sugar drops. But you also can't leave a really sick patient with another nurse while you eat lunch because she might be just as busy. I'm not promoting that. I don't think that. I think that they should have relief nurses in the ICU when there's somebody that's sick, but you know, it's just my thought. Okay, we'll move on. Diuretics, Lasix, like I said, if the Lasix doesn't work, we can move up to Bumex or Diaril. The other thing is we're using diuretics. So what does that leave us open for with electrolytes? What happens with Lasix when we give too much, or not too much, but we steadily give Lasix to somebody?
Potassium drops.
Huh?
Hypokalemia.
Yes. So what would we do with that? If they have reduced potassium, you would have to give potassium, right?
Right. Would you monitor their rhythm strips also?
Oh, definitely. Yeah, it's going to let you know because it's going to be alarming. And they usually go into ventricular tachycardia, and the problem with that is the next step for ventricular tachycardia is ventricular fibrillation. We do not want that to happen. So yes, we would be keeping an eye on their potassium, and we would give them a run of potassium or 2, however many they need, in order to increase their potassium. And then I said IV fluid administration. Okay. Here's a prone. This is a picture of proning, and you can see they have the patient on their stomach. They have a roll on each side, so they're, you know, they just seem to do better with that roll there. I don't know if they feel like somebody's there with them or, you know. And then they have their arms on separate, you can roll a blanket up or something so that their arm is not, you know, they don't have any problems with their shoulders.
It looks like how I normally sleep.
Huh?
I said that looks like how I normally sleep.
Yeah, yeah. And if it's more comfortable that way. Lateral rotation therapy, that's what I was talking about with the rescue bed. It can move back and forth, and it does it very gently, and it just keeps those fluids moving, you know, so that, you know, they don't become static, and then we have problems with pneumonia. And it works. I love rescue beds, but they are so expensive. Okay. So evaluation, no abnormal breath sounds. That's what we want to hear. Respiratory rate, depth, and rhythm are within normal limits for the patient. Use of accessory muscles appropriate for the level of activity. Decreased anxiety. That should be PaO2. I hit the S by mistake. And PaCO2 are within normal levels for the patient and normal breath sounds. Make sure you fix that PaO2. Get rid of the S. Okay. So, treatment for increasing or refractory shortness of breath. So, here we go. We got a non-rebreather face mask. We have these in the lab. They're usually in the basket on the tower there. In critical care, when people start their O2 sat starts to drop, we usually put these on them. We usually put the non-rebreather face mask. You do not need an order because in critical care you have protocols, and the nurses know how to follow those, you know, they know to follow those protocols. And if their sat starts to drop and it's in the 80s, you want to be putting something on that's, you know, it's going to work. Now, what you do is you put that non-rebreather face mask on. You make sure that that little bag is expanded, right? And then you hook it up to the oxygen, and usually 15 liters. And then it's good to go, okay? So non-invasive positive pressure ventilation, NIV, is the use of non-invasive positive pressure. It can reduce the risk for needing intubation and mechanical ventilation, as well as rapid improvements in the clinical condition of the patient. That's what they're using for some of these COVID patients. They're trying not to put them on a ventilator because it's harder to get them off, and they don't always respond very well. So they're using CPAP or BiPAP, and it's usually most comfortable for the patient since it offers some time period of lower pressure. It's not constant mechanical, the positive pressure going in, and patients will fight, a lot of patients will fight these ventilators. They don't like them, I don't blame them, but you know, it's better than the other alternative. Okay, so what's the difference between BiPAP and CPAP? The main difference between BiPAP and CPAP devices is that BiPAP machines have two pressure settings. One pressure for inhalation, and that can be set by the, well, it's written, the orders are written by the doc, and the respiratory therapist will set that. And a lower pressure for exhalation, okay? And that's also set. So BiPAP may also be used for patients who require some breathing assistance, okay? So patients who are candidates for CPAP or BiPAP should meet the following general criteria: that they are awake, okay? They're able to follow basic commands. They're able to protect their airway. not actively vomiting, and not having seizures. Okay? Can you see why they have these, why they have this criteria? Come on, guys, put your thinking cap on.
Oh yeah, I had a patient who was in the urgent care
Mhm.
for shortness of breath. It had been going on for about 3 days, and her PaO2
Mhm.
was down to 72%, and she could not catch her breath. And when I brought her back to the room, she became very delirious, could not follow any of my commands, could not ask any questions. Of course, you can only compensate for so long before your body just kind of gives up. And so the paramedics got there because we were going to send her over to the emergency room. And
Mhm.
instead of intubating her, they actually put a CPAP on her.
Mhm.
And me and the doctor kind of looked at each other, and the doctor asked the paramedics, "Why are you putting a CPAP on her?" And when she's not responsive, she can't follow commands, she can't even tell you her name. And she started leaking secretions out of her mouth.
Mhm.
And it was like this yellow kind of thick secretions.
Wow.
And she couldn't do anything about it. And so the doctor was like, she's going to aspirate that. She's going to get
Mhm.
pneumonia. She's going to get all this kind of other complications from that CPAP. And they would not intubate her.
Really?
Yeah, they would not.
Even with a physician telling them to?
Yeah, they were not comfortable with it. They were like, this will stabilize her until we get to the emergency room where they can intubate her. They were really not comfortable with intubation.
Wow, that is not good.
Right.
I mean, I wasn't there. I don't know, I mean, I trust what you tell me. Didn't get a chance to talk to them, but I mean, you have to, the main thing, protect the airway.
Right.
And that wasn't being done.
Right.
So, wow.
This was like 4 years ago. The doctor still talks about this.
Yeah, well, yeah, because, if this went to court, and this is always my thing, I was initially going to go to law school, and then, life got in the way. But I always think, if this goes to court, what's going to happen? Well, who is over paramedics?
The doctors, aren't they?
Doctors, right? The doctors, NPs, PAs, they are over paramedics. And if the doctor says you need to intubate this patient, and you know what? They didn't even have to use an ET tube. They have LMAs.
Right.
And they just, I don't know if does everybody here know what an LMA is?
It's a bit less invasive than.
Yeah, it's a mask, and it has a tube on it, and you put that down, and then you hook them up to the oxygen. So, yeah, and it protects the airway. Huh. Well, thanks for sharing that. Who is this?
Victoria.
Hi, Victoria. I would know your voice by now. You all sound the same now. Initial BiPAP settings, common initial inspiratory positive airway pressure, IPAP, is 10 cms per millimeter, 10 cms of water. Larger patients may need 15. The larger the patient is, the more problems you're going to have with intubating them, with giving them oxygen. It's just, physiologically, that's what has to be done. So expiratory positive airway pressure is 5. Adjust from there, usually by 2 to 5 centimeters if you have to go up. Okay. Rate of 10 to 12 breaths per minute can increase the rate if needing to get rid of more CO2. That's interesting, isn't it? Why would you increase the rate to get rid of CO2? What happens when you breathe out? What do you blow off?
You blow off CO2.
Right. So FiO2 initially is set at 100%, and then it's titrated down once stabilized. We cannot leave our patients on 100% oxygen. It causes more problems than not. So we start off at 100 and then titrate them down, okay? Reason we're starting at 100 is they're in respiratory distress. So then we're going to back down, you know, down and see how they do with the decreased oxygen, okay? All right, that's BiPAP. That's what it looks like, okay? So initial CPAP settings, and you know what, you're not going to have to know all this. Maybe I'll put on the study guide what you need to know, but it's not going to be all the settings, because that's, you don't, you know, you're not working in this. And when you have stuff, you have numbers like this, they can often get very confusing unless you've actually had a patient that you've had to deal with, you know, throughout a shift. And it seems, you know, we're adult learners, we do better with hands-on learning. All right, so CPAP settings. Initial pressure settings are usually around 10 cms per millimeter of mercury, and then adjusted based on the patient comfort or clinical response. So pressures range from 4 to 20 cms, and the rate of 10 to 12 breaths per minute can increase as the rate is needed. Same thing to get rid of more CO2. And FiO2 is initially set at 100%, then titrated down once they're stabilized, okay? And this is CPAP. It looks a lot like the BiPAP mask, right?
Mm-hmm.
Yeah. So, and you can see the ventilator right there. They're actually, what they're trying to do is that she's probably been extubated, and then they put her on CPAP, right? And see how she does with that. Keep her on it for a couple hours. Make sure she's not tired. Usually what they try to do when they start to try and titrate, get somebody off the ventilator, they'll have, hopefully the patient will get a good night's rest. Right? And then they'll start in the morning. And sometimes they can back down on the oxygen on the ventilator and see how they do. They're doing ABGs. Hopefully the patient has an art line in, because then they don't have to stick them so much. And then, you know, as they're seeing, okay, they're doing okay. They're doing okay with this. Let's keep going. Then they get to a point where they're like, you know what? I think we can extubate this person and put them on CPAP. And they'll put them on CPAP, or if, yeah, they can do that. They can put them on a T-piece instead of CPAP if they're really doing well. And it looks like it's hooked up, actually hooked up to the ventilator, and it's got like a little, looks like a little pipe piece there, and they put it in their mouth. And, you know, that's another way to deliver oxygen to them. Either way, they're trying to extubate them. They can leave them on that for a couple hours. They may, they probably do well. They don't like to take them off unless they're really, you know, doing well on the ventilator. Because why? Well, if they develop problems and they have to re-intubate them, that's a traumatic situation. If they extubate them and a couple minutes later they start to have, not wheezing, if they, laryngospasms, what they'll do is give them racemic epi. And that's something that they can put in a nebulizer, and they can put it on, they can do that with the CPAP too, and it relaxes the muscles in the throat. This is all extraneous stuff that I'm talking about, just trying to give you some background. I will point out what you need to know as we go through the lecture, but I try and talk about things that you might see in the future, okay? All right, so conditions that may require BiPAP: chronic obstructive pulmonary disorder, COPD. Why? Well, if we intubate COPD patients, they're difficult to get off of ventilator. Obstructive sleep apnea. You have a snorer in your house, that would help them, because a lot of these folks who have sleep apnea, they're snorers, they're apneic. They can develop severe heart disease from that. Obesity, hypoventilation syndrome. What do you think that is?
They're not getting enough oxygen to all their tissues because of
Yeah,
the,
and you know why? Because a lot of times all of this, adipose tissue here, when they lay down, it all pushes up on that diaphragm. I don't know if any of you have been pregnant before. When the baby gets really big, it's hard to lay down. Well, sometimes it's hard to stand up, hard to lay down. I didn't have that problem. My babies were born at 7 months and 6.5 months. So, but I've seen people, and when you push that diaphragm up, it's really hard for it to push down when it needs, you need to take the air in. Pneumonia, asthma flare-up, that's one of the things they're going to try to give them before they put them on a ventilator. But if they have a silent chest, they're going right to the ventilator, okay? Because that means they're not moving any air, right? Got that?
asthma.
Huh?
And that's with asthma.
Yeah.
Would they be afraid of the status asthmaticus for that reason?
That's what I meant. Yeah, I'm sorry. I should have said that.
Oh, no, it's
Yeah.
okay. I just wanted to make sure in my brain.
Yeah. If they're in status asthmaticus, wheezing, having a hard time breathing, and all of a sudden you don't hear any wheezing, that's not a good thing. That's a silent chest. They're getting ready to go into respiratory arrest. Okay? Poor breathing after an operation. Maybe they've had abdominal surgery and it hurts to take a breath. We've given them the max amount of pain medicine that they can get, and we can't give them any more. So, and they're still having problems taking deep breaths. Okay, you would put them on BiPAP. That's just something to help give them a little bit of boost and support them. Okay, neurological disease that disturbs breathing. Okay, so contraindications for BiPAP: respiratory arrest or unstable cardiorespiratory status. Uncooperative patients. Now, here's the thing. If they're uncooperative because their respiratory status is compromised, that's one thing. If they're just plain uncooperative, I can't see them keeping the mask on unless they're restrained. And then, you can, in ICU, you can restrain them and then get an order, but it has to be within a certain period of time. I think you can do that on the floors too, if I'm not mistaken. If they, they become very uncooperative, they're a danger to themselves, they're a danger to somebody else, then yeah. I mean, I have gotten hit in ICU, I've gotten stuff thrown at me, I've been bitten. So, those are uncooperative people. Inability to protect the airway, impaired swallowing, and cough. Trauma or burns involving the face. You want to be real careful with that. The only thing is, if they have, their face is really burned, they're going to have inhalation burns inside. And you want to be real careful that they are intubated, because what will happen, even if they come in and their airway is open, within a period of not even 2 hours, that airway can close very quickly. So they will usually intubate them. Okay. This is like minor burns, like, just, I would say 1st-degree burn. Okay. Facial, esophageal, or gastric surgery. Apnea, they have a poor respiratory drive, reduced consciousness, and air leak syndrome. They're just, they're not able to take the oxygen in adequately and then blow it off. Okay. So indications for CPAP. Any signs of significant respiratory distress, tachypnea, flaring, grunting. Well, if you hear grunting, it's like, okay, we need to give them respiratory support. And it's not just, the mask. You need to do CPAP, or they may have to be intubated. It all depends on what their SAT is, their O2 SAT. And in the meantime, somebody is also doing an ABG to see what, the patient's doing internally. Diseases with low functional residual capacity, such as pulmonary edema, meconium aspiration syndrome. This is for the little babies. Weaning from mechanical ventilation, tracheomalacia, and diaphragmatic paralysis. If that diaphragm cannot move up and down, then you need to give them support, respiratory support. Okay. So what are the contraindications? Uncooperative or extremely anxious patient. They're not cooperating at all. So what you would probably have to do is put them on a ventilator, which is going to make them even more uncooperative. And because the airway is protected with the intubation, they're probably going to have, they're probably going to order, they're going to be paralyzed, and they'll give them Versed. Okay.
I guess you couldn't give them that medication with CPAP, huh? Because they have to be able to be awake to follow commands.
Well, for CPAP, they have to be able to protect their airway.
Right, and they can't if you give them those medications. Okay.
Yeah. Did everybody got that? Yeah. Okay. Reduced consciousness and inability to protect. Oh, there we go. Protect their airway. Unstable cardiorespiratory status or respiratory arrest. Trauma or burns involving the face. And that what I should say is the degree of trauma or burns involving the face. You can use this for, like I said, first degree burns where there's no inhalation. And usually now I know you haven't had burns yet. What do you think would be a good indicator of someone who has inhalation burns? I'll tell you, but if you want to take a guess, you can.
Decreased oxygen saturation.
Decreased oxygen saturation, but also even before you do that, if they have soot around their nares, that means they've inhaled. Okay, and that is a good indicator of compromised airway. That's why we're real careful with the firefighters that come in, because my brother-in-law was DC fire captain, retired, but he's had his issues with inhalation burns, and his sister kept trying to get him to quit because of it. And that's not why he retired. He had to retire when he was in his 50s because he had AFib. But anyway, all right, facial, esophageal, or gastric surgeries. Okay, let's take a break. And how about if we come back at 10 after 10? Is that good?
Yes.
See you then.
Gina, I have a quick question.
Mm-hmm.
So like I had my first capstone last night.
Mm-hmm.
Do you want the paperwork if it's in the beginning of the week by Friday, right?
Yes.
Okay, I just wanted to make sure.
That's okay. All right, I'll be right back, guys. How about let's start back at 11:15, and that way we'll be on schedule.
You mean 10:15?
Yeah, what happened here? Oh.
Hey, Gina.
Yeah.
This is Nadia. Good morning.
Hi.
I just had a question about what is the biggest difference between the patients who are post vent going on CPAP versus people who need it for like maintenance for sleep apnea, or is just the settings are lower?
Yeah, the settings are different.
Okay.
Yeah. That's a very good question. I gotta figure out why this, oh, here we go. This is, there we go. Okay. Phew. Come here, Mom. I've got a couple more minutes. Yeah. What are you doing, huh? Want to come here? Come here. Molly, come here. Come on. You're getting so happy. Now it's time to go for walks.
Look
Okay.
at the puppy. Hi.
This is Molly. Hi, Molly.
Hi, Molly.
She's a big girl. And she's asleep. Molly likes to chase the deer, don't you? Hmm? I'm gonna be a big girl now. Mama's got to teach. Okay. Okay. Is everybody back or? Oh, I wouldn't know because I don't. Hi, Charlie.
Oh, hi.
How are you?
I'm okay. I'm sorry. I'm okay. Thank you. How are you, Professor?
How was your capstone last night? Voice.
It went well, man, but it went well. Thank you. But it's hard. I don't know, for people who went last night to be able to be up this morning for the class, right?
I know. I know.
Right, Sam? How do you feel? Tired, right?
Well, I've been up since 4 yesterday, so I'm struggling.
Oh my
Why
God.
have you been up since then? Did you have capstone last night?
Yeah, that's why I asked when you wanted the paperwork too.
Did you send me your schedule?
Yeah, I did. I sent the schedule and the evaluation,
Pardon me.
which actually is a little ironic because last night in the labor and delivery, while I was in the NICU, we had a baby who was put on CPAP last night.
Oh, Well, that was good for you to be able to see.
Yeah.
Baby
Yeah.
okay?
Yeah, the baby's stable now. He was fine shortly after. I'd say probably about 6 hours later. They took him off everything, but it was interesting and a little hairy there for a while, but
Yeah. Those little guys, it's, well, with children, it's always respiratory, more or less, unless they have an underlying congenital heart problem. But
yeah, he was in the birth canal too long, and he just came out not breathing. So
yeah. And with him, did they have the, instead of putting like a mask on him, did they have like a dome or something? that they
no,
put-
I actually got to hold the CPAP mask on him while they were doing everything else. So,
Oh.
yeah.
Was he average, was he like full-term baby or?
He wasn't full term. I think he was like he was only slightly premature, but he was a big baby for
Oh.
his age. He was like I think he was like 8 pounds.
Wow.
Yeah.
Yeah, I make 2 of my babies. Plus some left over. So, okay. Let me see. It's time. So intubation, we can go right into that. So, pardon me, indications for intubation and mechanical ventilation, apnea or acute respiratory failure, failure to protect their airway, all of these are indications. Hypoxemia, unresponsive to oxygen therapy alone, and we talked about that with ARDS. Increased work of breathing with progressive client fatigue. It can only breathe like this for, a short period of time before they start to wear out. Now, if you're younger, you may last a little bit longer. Older, not so much. You can't go as long as the others. Bottom line is increased work of breathing and they become fatigued. Okay. So, maintaining a patent airway through positioning and the insertion of an oral or nasopharyngeal airway until the patient is intubated. Oral intubation is much preferred over nasopharyngeal because that's exactly what it sounds like. They intubate through the nose and then go down the trachea. It's not comfortable at all. I mean, it's bad enough with intubating them through their mouth, but when you intubate them through their nose, it hurts. So there's not a whole lot of room in there, a little bit more room in the mouth, okay? So nasotracheal tubes are placed into trachea via the nose in circumstances when there's an anatomy problem, trauma, a procedure prohibits placement directly via the mouth. They may have cancer of the mouth. You can get cancer anywhere. They may have dental problems that, or swelling, their tongue may be swollen. So then you definitely would have to intubate through the nose. Those patients, if they're going to be on a ventilator for a while, they really need to get trached. Even ET, when they go through their mouth, that's another time, if it's going to be for a while, they need to be trached. But these nasopharyngeal intubations, like I said, are very uncomfortable. So we would really need to trach those patients. So this is a picture. Where's my pointer? Can you see when I use my pointer?
Yeah.
Okay. So right here is the ET tube. This is the balloon I was talking about before. And it goes down here to here where it lodges in the trachea and it's blown up. We want to make sure that balloon is firm but not hard. So, but anyway, this is the tube. It's the same as we use for intubation through the mouth, okay? An ET tube goes in the nose and comes down into the trachea, okay? Very uncomfortable. So endotracheal tubes are placed into the trachea via the mouth in order to establish a patent and stable airway for patients. characteristics of an ET tube, there are numerous sizes available, from neonate, and they're little tiny tubes, to adult. The size is dictated by the patient's anatomy. And if you work in critical care long enough, and you're waiting for the respiratory therapist or the intensivist or the ER doc to come intubate the patient, you will get used to looking at them and saying, I think they need a 7.5, or, you know, boy, this guy's really big, football player big, okay, he's probably gonna need an 8.5. So, all right, let me not get ahead of myself. The tube has a 15 millimeter adapter for adults, which connects to the conventional resuscitation bags, as well as to the ventilator tubing. So let me show you what I'm talking about. It's this right here, okay? A radio peg line that will appear prominently on the x-ray runs the length of the tube, assisting assessment of the tube length. Let me show you. This is it right here. This is the radio peg line. That shows up on the x-ray to let them know, because after you intubate somebody, of course you listen, and you know, you can usually hear whether it's, you know, right at right where it should be, at the top of the branching out of the lungs, or if it slipped down into the right lung, which can happen sometimes. And you always confirm intubation with an x-ray, always, okay? So let's go back down here. Okay. So the distal end has an inflatable cuff, inflated via a port balloon located at the proximal end of the tube. And we talked about that. There's the balloon, and down here is the other balloon that keeps it in place, okay?
Do both balloons go down in there, or just the one that's on the
No,
the
this one stays outside.
Oh, okay.
And see, it has a little tube that runs down here, and you place on the end here, you're going to put a 10 cc syringe, or 5. Usually you don't use 10. I would say 5. Use a 5, and you're going to inflate it. You're not going to be able to see this while you're inflating it, and that's why I said it has to be firm but not hard, not rock hard.
Well, that's what I was trying to wrap my head around. How would you know that it's hard? How would you be able to feel that? If it's blowing up the other end.
This one here is going to be your indicator.
Oh, okay. Okay.
If this one is hard, then there's too much air in this one.
Okay, gotcha.
Okay, got me? Great. Yeah. And here's, pardon me, here's a picture of the ET tubes. They all have balloons. They all have the little indicator here. Here is the radio peg line running down here. This one has a light blue one. There is no difference in these, just difference in color. These little adapters will adapt to the ventilator tubing, or to you call it, a bag, so you can bag the patient. Okay. Pardon me. Not what else I was going to say. Let me see. But you can see here. I mean, look at your mouth. That's how, you know, that's how you take air in. Then you're breathing through these tubes. Okay. It can be scary for patients, you know. The other thing is, when you take this ET tube out, if you're not real sure about what they're going to order, I would take a couple out, different sizes. They'll tell you what size they're going to use. You have to hurry up, make sure that this balloon down here inflates. You're going to put the air in through here. Make sure this inflates, because if you get them intubated and there's a hole in this balloon, or for whatever reason it won't inflate, they have to take that tube back out and intubate the patient again. So what you want to do is you want to make sure that that inflates. Also, you're going to have some lube there. It gets lubed. and you put a stylet in that looks like a coat hanger, a straight coat hanger, and put that in there, and it makes that tube straight and it makes it hard, because you cannot intubate with a tube it's real wobbly. It just won't work. Okay. So, okay. So after intubation, you should note the length marking of the endotracheal tube with reference to a landmark such as incisor teeth or nares. I prefer, and I'm, for testing purposes, that you use the teeth. Teeth are pretty stationary. The nose, you can have swelling, the nares, and we always use the teeth. Now what you do is, and you would also document that. You would say 24, ET tube 24 at the teeth. Okay. Let me see, where was I? This will help you monitor the endotracheal tube position, and you do this to detect if it has moved outwards or further down into the bronchus. If you come in the morning and it's 24 at the teeth, and that's what it was when they were intubated, and then you go in and, or your CNA goes in and they move them around, they wash them. And then later when you assess them and say it's 26 at the teeth, okay, something's moved. So, and we're not allowed to advance it or pull it back. So you have to call the physician and they'll come and do it. Hopefully you have an intensivist in the ICU, so they can do that. Okay. Prior to intubation, the physician or nurse practitioner or RT or PA may decide to sedate the patient. Common medications for this purpose include etomidate, succinylcholine, but we talked about succinylcholine because it causes hypokalemia and other problems. We're only going to use that in, if we need that patient to go under very quickly, or they're fighting us and, we're losing the battle pretty much, because succinylcholine works very quickly. Rocuronium, propofol, midazolam. Okay. Fiber optic. This right here is the fiber optic camera. The docs that use this are specially trained. These are usually used for patients who are morbidly obese. They have a short neck, and because of the obesity, especially around or swelling in the neck area, they use the fiber optic and they can go down and they can see and visualize, and then they can intubate the patient. Or they'll use a blade. Right here, you have to, this is battery operated. Why? Because there's a little light all the way at the bottom here, okay? And when they put that in their mouth, they sweep the blade off to the side. They visualize the vocal cords. In order to be able to do that, they have to have a light. So then they, go for the vocal cords. Once they go past those, they got it, okay? Well, hopefully they don't go down too far, but that's why we get a chest x-ray, okay? To make sure that it's, right at the top of the lungs so that it goes to both lungs, all right? And it hasn't slipped down into the right bronchus. All right, so here's the doc or whoever, the healthcare provider, doing fiber optic intubation. Usually it's used for difficult intubation such as morbidly obese patients. And then here's a doc using a blade, and you can see right there, visualize the vocal cords are right here, and they slip the tube in and goes right there, okay? And you can see right here, they have an NG tube. See that? All right. Verifying tube placement. You can do that with end-tidal carbon dioxide with a reader, and we'll show you one of those next week. The ones we have are disposable ones, and they're really kind of cool. So we'll show you that. Make sure I put them in here. Carbon dioxide reader. And basically what it does is tell you if the carbon dioxide levels are too high. And if they are, that means you don't have them intubated properly. Okay, chest x-ray, we said we would have to verify that. Assess for breath sounds bilaterally, symmetrical chest movement, and air emerging from the ET tube. All right. So nursing care, assess tube placement, minimal cuff leak, breath sounds, chest wall movement. You're going to do that every time you assess this patient. Usually in the ICU, you're going to be assessing every 2 to 4 hours, sometimes every hour. So, you know, it all depends on the condition of the patient. Prevent movement of the tube by the patient. We don't want them pulling the tube out. This is, and they will do that sometimes. If they're fine, they're awake, you know, they're watching you move around the room. They're actually trying to communicate with you, and but they may fall asleep, and you know, in their sleep they may, you know, try and pull it out. So I really think that they should be restrained, just have their hands restrained. And I always told them, I told them, this isn't a restraint, and it's not a punitive thing. I said, this is just a reminder not to pull out your ET tube. And when they were totally awake, and I knew they weren't going to pull the tube out, I would loosen the restraints. So it's really a call on, you know, the nurse. The nurse is the one who would be the one to decide whether or not they want to keep those on. Check the pilot balloon, always. Soft restraints, I said that, and mechanical sedation if needed. Okay. So goals of mechanical ventilation: relief of symptoms of respiratory distress, rest for fatigued muscles of respiration, decrease in the work of breathing, improvement in oxygenation, improvement in ventilation, restoration of acid-base balance. That's one of our primary goals. Stabilization of the chest wall. Because if the chest wall is not stable, they're not going to oxygenate properly. When we say stabilization of the chest wall, we're talking about those sternal retractions, the uneven breathing. These are all unstable chest walls, okay? And provision of anesthesia. If you have a patient under general anesthesia, they need to be ventilated, mechanically ventilated. And this is a ventilator. I had a ventilator before COVID struck, and then the state of Maryland asked for our ventilator. Now this ventilator was really old, and it even had 2 wheels falling off of it, but they were so desperate they took it. So my ventilator is somewhere in a warehouse in Maryland. I can't imagine that somebody would use it, and we're trying to find it. But anyway, and God bless Matt, he's trying. But I don't have one right now. But anyway, this is good. This shows you, this is a ventilator control panel. And basically you don't have to know this stuff because it's really, some of it is detailed, but we're going to go over it. It's tidal volume, respiratory rate, peak inspiratory flow, sensitivity, percentage of O2, you can control that. Plateau, that's more of a respiratory therapist thing. High pressure limits, low inspiration pressure, low PEEP or CPAP, low exhale tidal volume. So the tidal volume and we're going to talk about that, the tidal volume that you put into the patient, the pressure with the oxygen that you put into the patient, all of it's not coming out. That's basically what they're saying. High respiratory rate. These are all things that you're going to look at, but you don't have to know them by heart. And these are the different settings. So let's go on. Let's see. Okay. Nursing diagnosis for mechanically ventilated patients, impaired gas exchange related to alveolar capillary membrane changes and ventilation perfusion imbalance. Ineffective breathing patterns related to hypoventilation, pardon me, hypoxia and or inflammatory process. Impaired verbal communication related to presence of artificial airway. Decreased cardiac output related to altered preload and stroke volume, and risk for infection related to presence of artificial airway. So medications associated with mechanical ventilation, benzodiazepines, diazepam, Valium, lorazepam, which is Ativan, and midazolam, Versed. Intravenous morphine or fentanyl analgesia will inhibit respiratory drive, so you have to be careful. They're on a ventilator, so you can compensate for that, but you have to make sure that they're compensated properly. You're trying to protect everybody. Neuromuscular blocking agents to induce paralysis and suppress ability to breathe if the client is breathing against the ventilator. And you will hear that referred to as bucket vent. Okay, so here are the different modes. Controlled mandatory ventilation, which is tidal volume delivered at the set rate independent of the patient effort. And this is rarely used. Why? Because it totally takes over their breathing. All right. Now, we will use that if they're, on under general anesthesia, because there's no respiratory drive there, but not in the ICU setting or, the ER. Okay. Target population, apneic patients, neurotrauma patients with no respiratory drive. Nursing implications, patients may be sedated or have induced paralysis. All right.
I have a question.
Yeah.
My mom had pneumonia, and she was, this was in Manassas, but she had pneumonia, and she was on the BiPAP for over a week. And then the doctor said that he wanted to put her on the ventilator to give her lungs a chance to rest.
No. Okay.
I never heard that before, but once they put her on the ventilator, 4 days later, I had to take her off of it, and she didn't wake up. But I didn't know if that was something that's common that they do, because I had never heard that before.
Are you saying as that your
Like
mom
giving them on the vent, because she was, the BiPAP was, her whole face was completely chapped from all the air and everything. She was struggling to breathe. Her, she wasn't reacting to antibiotics. So they put her on the vent. They said to give her lungs a break for a couple of days. And I didn't really understand that.
I have not seen that before.
Okay.
They're not doing it in certain hospitals, but was her O2 sat okay? I mean, was her ABGs looking all right, or it doesn't sound like her?
She was declining after about the second week. Things started looking bad, but the doctor had talked her into it when I wasn't there, because she had told me she didn't want to be on a vent, but he had talked her into it to put her on a vent before, when I wasn't even there, and then I had to deal with the aftermath of it. But
were you the what do you call it,
medical power of attorney?
Yeah.
So I had to take my mom off the vent, and that, I don't know if that could have been prevented. I don't know, because that's not something that you really ever want to do.
If she was not, if she was end stage, I don't know that much about your mom, what happened, but if she was end stage, I don't see the reasoning for doing that.
I didn't either.
Yeah, well, some
It is what it is.
yes, some doctors, it's hard for them to give up. Especially the older docs. The younger ones are, not that they're going to give up on their patients. That's not what I'm saying. some docs, the older docs were, you know, I have to heal everybody and, you know, I have to do this. There are just some patients that you cannot do that for, and you just prolong their suffering. And it sounds like that's what happened with your mom.
Yeah.
Yeah, I mean, I know with my mom, there were a couple times I had to put my foot down and say no. And, you know, I even had a doctor say, well, let me explain this to you. I said, you don't need to explain it to me. I understand it. But no, because she's going to be suffering and I'm not going to have that. So, you know, you'll hear a lot of nurses say, if you're going to go to the hospital, you need to take a nurse with you. Because
Yeah, because the doctor tried to talk me into leaving her on the vent. He said, well, she can live for months on this vent. And I said, absolutely not. Absolutely not.
quality of life.
Yeah. So, yeah.
It wasn't a Catholic hospital, was it? Or
I can't try. It's Prince something, Prince Harry or Prince something in Manassas. I forget what it was called.
okay, so it wasn't a religious associated
No.
hospital.
Uh-uh.
Sometimes that happens too. Well, if, you know, like we have St. Agnes here in Baltimore, they will not honor, do not resuscitate if they feel like the patient is viable. So, you know, kind of takes people, you know, takes the control out from the family.
Right.
I'm really sorry that happened, and it's hard.
Okay.
Hard to deal
Yeah.
with. Okay, so tidal volume delivered at a set rate. This is assist control ventilation. Tidal volume delivered at a set rate in response to the patient's effort. If the patient fails to breathe at a predetermined time, the ventilator will deliver a breath. I'm sorry about the birds. They're upset about something. Target population, patients able to breathe spontaneously, but they have weak respiratory muscles. Okay, and there you go, assist control. Okay, they're being assisted. Nursing implications, the patient is unable to hyperventilate if the volume controlled or may become hypercapnic if pressure controlled. So that's why they put them on the assist control. This is the setting that they normally use, the SIMV, synchronized intermittent mandatory ventilation. And what this does is the tidal volume is delivered at a low set rate in response to the patient effort, while allowing the patient to spontaneously breathe in between, okay? So say they set it at 8 or 10, and they, you know, the respiratory therapists are the ones that keep an eye on this, but the ICU nurses, being ICU nurses, they have to see what's going on. And, you know, the patient will breathe 8 to 10, with the machine will breathe for them, but then they may breathe up to 10 times more spontaneously. So what they do is they'll chart it as 10 SIMV and 10 patient generated or whatever, okay? And that helps them to see the progress that these patients are making towards getting off the vent. The target population are patients who cannot sustain spontaneous ventilation for extended periods. They may not do well with, they may start out doing very well, and then, you know, as they go through this, they become more tired and not able to sustain that. So it's useful as a weaning mode. It increases the work of breathing. But like I said, they prefer to use that. Now, during the evening, if the patient's going to sleep during the evening, if, you know, and some of them do, the nurses are happy if they do, some of them do not. But then if they're going to sleep, they might increase their SIMV rate to, like, we'll say 12 to 16, just to make sure that they're adequately ventilated. Okay. Like I said, you don't have to know these. I'm just giving these to you as an example of what happens so that some of this stuff makes sense to you. You will have to know them if you go into critical care, okay? Continuous positive airway pressure applies positive pressure during spontaneous breaths. It's effective as a weaning tool or training, weaning trial or training mode. I'm trying to see something. Patient must be monitored for respiratory. Oh, what happened? Are you guys still there? Hello? Oh,
Yes.
boy.
We're still here.
Oh, okay.
Yes.
I don't know what I did. What did I do? Hold on. I pressed on something and I shouldn't have pressed on it. Yeah, okay. Oh, now what happened? No? Hold on. See, this is what happens when I, where's my, here it is. Try this. I know, I'm just trying to get back from it. Come here. Sorry guys, I'm trying to, can you see the screen?
Yeah, I think what you did, I think you just zoomed in a little bit.
Really?
Is what it looked like from our end.
Yeah, we can see.
You can see, but I can't.
You can't see?
I can't see the screen. Oh my, one of these days. Hold on.
Did you minimize it?
Let me see. I got hide video panel. Maybe I share. Nope. Oh my. You know, all I did was press one little thing. I hate technology. Well, okay, but I need to. Wait a minute, let me try something. No. Try something here. Sorry, guys, I'm just trying to figure out what I did. Let me go. Oh. No, I don't want that. Let me go here, and then I'll come back. Okay, then I'm gonna do this. There. Okay. Can you see it still?
Yeah.
Okay, thanks.
Yes.
All right. Now it wants to be cantankerous. There we go. Okay. Types of ventilator settings. This is what I've been talking about, positive end expiratory pressure, or PEEP. It's a positive pressure used to decrease the patient's work of breathing. It's typically set between 3 to 10 cms of water. Pressure helps keep the alveoli open, preventing atelectasis, where they collapse. The higher pressure distends the alveolus, providing a greater surface area for gas exchange. Okay, nurses must monitor patients' BP during increases in PEEP, as the increased interthoracic pressure may cause compression of the vena cava and decreased preload. We talked about that. Okay, does everybody understand that?
Not really.
Is this Nadia?
Yes.
Okay, what is it that, I tell you what, we'll talk, you and I talk after we get through this, okay?
Okay.
All
Okay.
right. Okay. So PEEP is the same as one might envision blowing up a party balloon. remembering how hard it is to do so before the pressure inside the balloon exceeds the atmospheric pressure. Okay, in other words, you put more pressure in the balloon when you're blowing it up. You know, when it's smaller, it's not, the atmospheric pressure is more. Once you put more pressure in that balloon, then it's easier to blow it up, okay? But once enough air is pushed into the balloon and the atmospheric pressure is overcome, the balloon is much easier to inflate. The lungs are very similar in that the majority of the work of breathing coincides with moving the ribs and overcoming atmospheric resistance to chest expansion. All right, so your body responds in that way. The work of breathing decreases, allowing the patient to expand the chest more fully while expending less energy. Okay? So care of the client on a ventilator. Continuous, continuous monitoring of ventilator function, continuous oxygen saturation, frequent pulmonary assessment. The client needs suctioning of respiratory secretions with sterile technique. Hopefully you have the whole inline AT tube with the inline suction equipment. And what you do before you suction this patient, you're going, there's a button on the, wait a minute, where are we at? I'm trying to see. That's what I was trying to see before. Wait a minute. No, wrong one here. No, it doesn't tell me. Okay. Well, let me show you. I'll have to try and, where was the, right here. Okay, there should be 100%. This one doesn't seem to have it. I guess this one you have to change it manually. But usually, oh, here it is. Here it is, right here. That, you would hit that. You would give them 100% oxygen. And then you're going to suction them out. Okay? Now, here's the thing. Oh, did I go through this? Here. You were not going to suction any longer than 10 seconds, okay? When you put the tube, you put the suction catheter in, you turn it as you bring it out. You do not put suction on the patient while you are putting the catheter in. That can cause damage. You put the catheter in, you start to suction them out, less than 10 seconds, and as you're bringing the catheter out, you are turning it, okay? All right, so while suctioning, if the client's heart rate drops, stop suctioning and reoxygenate the patient with 100% O2 on the ventilator. All right, emotional support and sedation to the client is necessary, and the means of communication for client if they're alert. You tell them, if they're alert, I'm going to have to suction you. And, we've done this before. It's, it doesn't feel great, but I have to do it in order to get those secretions out of your trachea, because we're trying to get you off this vent. And the longer we have to deal with all these secretions getting in your lungs may cause you to get pneumonia, which is not good. So, you just explain to them why you have to do it, because they don't like it. If there's family in the room, please explain to them, because they think you're hurting the patient. So just tell them what to expect and why you're doing it, okay? Care of client on event, okay, these are important. High pressure alarm on event will signal the patient is biting down on the endotracheal tube. If they bite down on the tube, there's more pressure in the tube, okay? The patient may need to be suctioned because there's pressure in the trachea, in the ET tube, because there's something in there other than the space needed to bring oxygen into the patient. So it's meeting resistance, higher pressures. Ventilator tubing may be kinked, or there's water in the ventilator tubing. And that's not the ET tube. That's the actual ventilator tubing, the blue tubing that you see on the ventilators. And usually the RT will come in, the respiratory therapist, and they'll dump the water into a graduated cylinder. You know, if they're not due to come, and this is the only reason why this thing is, why the ventilator is alarming, you can dump that water and then hook it back up to the ventilator and the patient will be fine. But you need to know these high pressure alarms. You need to know the low pressure alarm will signal for a disconnected ventilator tubing or an endotracheal tube leak. If the patient pulls the ventilator tube out, the ET tube out, and hands it to you when you walk in the room, like that happened to me. So it's a low pressure alarm that'll come up, because there is no, if it's out, there's no pressure that, like if you would have it in the throat where it's a closer space. If it's out in the atmosphere, and it's just no pressure there. All right, so fostering patient and family-centered education. Patients and families need to understand why, understand why mechanical ventilation is necessary, as well as the potential risks. And this will save you a lot of headaches if you explain everything to them before they go in the room. You say, when you go in, they're going to be ventilated. They're going to be on a ventilator. They're going to have multiple drips up. They're going to be on a monitor, you know, whatever other thing. If you're doing CVVHD, continuous dialysis, or if they have a balloon pump in, you need to explain all this to them, what they're going to be seeing, because it can be quite a shock to them. And I had one lady got in the room and she fainted. Thank God I was close to her, because I caught her before her head hit the floor. But, you know, you have to make sure that you explain things to them. Explaining why suctioning causes the patient to gag may not make it less comfortable, but it decreases the anxiety for the patient and for the family. Explaining the alarm system on the ventilator, ECG monitor, and infusion pumps decreases anxiety. If the patient is alert and they hear these alarms going off, they may become very concerned. So you have to let them know, I'm not far away. If the alarm goes off, I will be right here. And if for some reason I can't come in, somebody else is right here. So you don't have to worry about it. That will decrease their anxiety. Let the family know that the patient can still hear if they're not responsive, and encourage the families to touch and talk to the patients. Okay, that's the big thing with COVID. Families are not allowed to come and stay with their loved ones, and many people have died alone, and that's very sad. And of course, the nurses are there, and they always, you know, help them. In fact, I think a couple of the nurses were calling home for the patients and letting them talk. They had what is it, not laptops, but the, I don't know, the other computers, and that way they were able to call home and talk to family members, or just have the family talk to them. So it's very important. Human touch and being able to talk to patients is very important. I had a patient who, I may have told you this already, this story. Was in the ICU. It was an ICU, CCU. Got him up from the cath lab. Did I tell you this? About, he was on a balloon pump, multiple drips. What else was wrong with him? He was on a ventilator, and he was totally out, you know. But I kept talking to him. He was my only patient because he was ventilated and he was on a balloon pump. and the balloon pump requires you to check it every hour. So I talked to him. I told him it was in the spring, and I was telling him about how the flowers were blooming, and it was a sunny day, and you know, well, that was just your doctor, you know, and this is what he said, and this is what he meant by when he said it, or she said it. And I talked to him a lot because I was the only one in the room with him. And so I went home that night. He's still ventilated. He wasn't showing any signs of getting off the ventilator. And when I came back that Monday, I was sitting outside of his room, and this was before HIPAA and everything else, and I was getting a report from one of the other nurses. He was not my patient that day. I didn't have time to ask how he was doing. So we were really busy on the unit. So I'm sitting there getting a report, and I'm talking to the nurse, and I hear this voice come out of the room, and they said, "Is that you, Gina?" And I was like, got up, went in, and he was awake. He was off the ventilator. He didn't have the balloon pump anymore. Yeah, it was like, I think it was 4 days between. And I said, "Oh," I said, "Hi." And he said, I said, "How did you know it was me?" He said, "I remembered you talking to me." He said, "I didn't hear everything you said." He said, "Because I was falling asleep in between." He said, "But I remember you talking to me and you telling me that it was a pretty day out and the flowers were blooming. And so they do hear you. So watch what you say around them. Watch what, the doctors think they can talk in the room. They should really go out of the room to talk, to the family, because those patients do hear most of the time. All right, nutrition. The role of nutrition in critical care cannot be underestimated or understated, and I said that earlier, yesterday, I believe. Early enteral nutrition reduces mortality in critical care if started within 24 hours of injury or critical care admission. So it reduces bacterial translocation, prevents mucosal atrophy, and maintains normal mucosal permeability. Nurses play a role as advocates in the multidisciplinary team, and a nutritional consult is an important start to ensuring that the patient receives adequate nutrition. Okay. I don't even know where I am in this thing. I can't see. Okay. Does anybody know what slide we're on? Sarah, you know what slide we're on, huh?
This is it. This is where we are. Weaning from the vent.
No, I mean the number.
Oh, 187.
Okay, thanks. Okay, 187. All right, that's cool. 228. Okay, all right, good. Okay. So the process in which support from the mechanical ventilator is reduced and the work of breathing is assumed by the patient. The process of removing ventilator support and reestablishing spontaneous respirations. Underlying problem for respiratory failure must be corrected or stabilized. Okay. We talked a lot about weaning from the vent. So what are the weaning parameters? They have to have stable vital signs. Their respiratory rate cannot be overly high, because that means that they're having problems with becoming oxygenated. Dyspnea, blood gas, and oxygen saturation, you're looking at all of those, okay? And overall clinical status, condition that, say their sepsis is starting to get worse, but they're doing okay on the ventilator, you're not going to take them off the ventilator, because we have to deal with this sepsis, which may go into ARDS, because, especially if it's gram-negative sepsis. So these are all the things that you think about when in critical care. You're always thinking, well, what if, okay? This is a T-piece I was telling you about. Typically, the rapid shallow breathing index is obtained either on a CPAP or a T-piece. And this one doesn't have the little pipe on the end. They would usually put in their mouth. With the T-piece, the patient is removed from the ventilator, and an oxygen source is connected to the endotracheal tube. And if they can tolerate that, and they don't tire out too fast and they seem like they're fine, they may try to extubate them if their ABGs look good. Okay, weaning process and evaluation. They may use a T-piece or CPAP for weaning if the ventilator time is short. Vital signs, we're going to look at oxygen saturation. ABGs, we're going to look at the CO2 and the PO2. When well tolerated, we will extubate. Well, we won't. The physician or the respiratory therapist will extubate the patient. Another thing I forgot to, I don't know if I mentioned it or not, is respiratory therapy can also intubate patients. Now, not every facility may allow them to do it, but they are trained in that aspect. Okay. Okay, so removal of the endotracheal tube. You're going to hyperoxygenate the patient. You're going to press that 100%, or they are, 100% O2 on the ventilator. Thoroughly suction the ET in oral cavity. Rapidly deflate the cuff of the ET. You're going to do this all at once. Remove the tube at peak inspiration and instruct the patient to cough as you're, when you pull it out. Okay. And the other thing I want to caution you on is to put like a chucks here, because when that tube comes out, sometimes it comes out with other stuff too, like, secretions, we'll just say. Monitoring after extubation is essential. If the patient develops stridor, the nurse should notify the emergency team immediately. And that's what I was talking about before. They would give racemic epi, and they put it in a nebulizer. Okay?
Question, please.
Yes?
Yeah, when you said hyperoxygenate the patient, does that mean the patient would be on on oxygen with nasal cannula and stuff like that? Is that what it is?
No, but I'm talking, when I say hyperoxygenate them with 100% O2, that's before they're extubated, and that's the button on the ventilator that I showed you.
Yeah.
Let me go. It's right here.
Okay.
You would press that button,
Mhm.
and it gives them 100% oxygen for a certain period of time. It's not a long time. And then you would go to the process of extubating them.
Got it. Okay. Thank
Got
you.
it? Okay, you're welcome. I wasn't. Yeah. Okay. And I was talking about stridor. Stridor doesn't mean that they're not ready to come off the ventilator. What stridor is there's swelling in the throat. So you give them the racemic epi, and that usually takes care of the swelling. It'll bring the swelling down. And they may have to be on steroids for, a couple more days because to keep the swelling down and decrease it. Okay. Okay, so tracheostomy for long-term intubation. You guys want to take a break? No? Just want to keep going? Huh?
I'm okay.
Okay, let's keep going. Tracheostomy for long-term intubation. If the patient is going to require tracheal intubation and ventilation in excess of 21 days, an early conversion to tracheostomy should be considered. Okay. All right, so here are the advantages. Prevents further injury from the ET tube. Now, when we put the ET tube in, and I'm going to show you this, they have, it looks like a shield, and in the middle, there's a hole cut out, and that's where they put the ET tube, and then there's a little part that comes out here, and they tape the ET tube to that, and that's great. But you can have problems here where they start to get a rash, or you can have breakdown with the lips. So switching it to a tracheostomy where they have the ET tube or the tracheostomy tube in there, and they hook the ET tube to it, not the ET tube, the ventilator to it, then it's much better for them. And that's usually in excess of 21 days. It increases the patient's comfort. It's more secure for verbal communication. and it permits verbal communication, and it facilitates oral nourishment. Okay, they can eat. So, and that's one thing I can remember a lot of the patients saying, you know, geez, I wish I could just chew something and eat it. You know, they would write it on a piece of paper. And, you know, I'll say, well, it's coming. It's, you know, you just got to get a little bit stronger. And then, you know, we got to make sure that you're strong enough to swallow your food. So, and they understand when you're trying to tell them, especially if they trust you. You have to build a lot of trust with them. And so then they're able to eat, and, you know, if they have a tracheostomy in, and it's much better for them. Oh, cancer of the nose and sinuses. So cancer of the nose and sinuses, tumors of the nose and sinuses are rare and can be benign or malignant, okay? The onset is slow and manifestations resemble sinusitis. Who in Maryland doesn't have some kind of sinusitis at one time or another, you know? So it's very difficult to diagnose this at first. Local lymph enlargement, that would be right here, occurs on the side with a tumor mass, okay? Radiation therapy is the main treatment. Surgery will also be used, okay? That's it for that, okay? Laryngeal cancer, anatomy and function of the larynx, and you can see, here's the anatomy, the larynx, and you can see the tongue, the epiglottis, the vocal cords, the trachea. I'm using my finger, but I always forget to use this. And the esophagus, okay? So here's the examination of the vocal cords. This is what I was talking about real quick when I talked about whoever's intubating the patient visualizes the vocal cords, and this is what they go for, right here in the center. All right, now, there's a disorder. These are normal vocal cords, okay? This vocal cord has contact ulcers. A lot of singers get those, you know? I know Celine Dion had problems with that at one time. Right here, the next one has a polyp in the vocal cords, and they have to be removed, okay? Here are little nodules. You see them tiny little nodules? Here's unilateral paralysis. You have one of your vocal cords is paralyzed. These people have to be careful with aspiration, you know, because one side is not working properly. And this last one is cancer. And you can see that the overgrowth of the cells, okay? Laryngeal tumors are uncommon and often curable if detected early. Some of the, one of the precursors for getting this would be tobacco, smoking, okay? Also drinking in excess. Tumors may be benign papillomas. Cancer, there will be squamous cell cancer, okay? So, and I've had, like I said, I worked at GBMC, which is surgical hospital, and I had patients, a number of patients come in with laryngeal tumors, and I worked very closely with them, and they would come in. One of the earliest signs of laryngeal tumor is hoarseness when you're talking. Okay, and that's bolded and it's in red, so you know, something you want to study. Change in voice, painful swallowing, dyspnea, foul breath, palpable lump in their neck, and an earache. An earache was one of the biggest things that they had. You know, they would come in pre-surgery before, you know, they went back, and I'd say, well, how are you feeling today? Oh, my ear hurts so bad. I'm like, oh, well, let's make sure all your consents are signed, and then I'll get you something for your pain. So, diagnostic tests, laryngoscopy, biopsy, and imaging studies. Okay. Treatment / surgery, they get radiation treatment, chemotherapy, laryngectomy, partial or total laryngectomy. If they get a partial, they can still talk a little bit. Total, they have to, you know, if they want to talk, they can put their finger over the hole that's there and they can try and talk. They also have the, I think I have a picture of it in here. Here's one with the, remove the larynx, and here's the stoma that comes out. Okay, this is after surgery. Let me see if, I know I thought I had, hold on, let me look. Yeah, I do. Okay, we'll talk about that in a minute. The first priority after head and neck surgery are airway maintenance and ventilation. Okay. Wound, flap, and reconstructive tissue care. They will take reconstructive tissue from the arm or the thigh, where they can get a good piece of skin to use as a flap. And they really need to let you know that ahead of time where they're going to take this flap. You're not a mind reader, you don't know that. And because if you're in pre-op and you're putting an IV in, how are you supposed to know they were going to use that arm? It's a voice of experience. All right, hemorrhage. These are the things you have to look for. Wound breakdown, pain management. Make sure that they know that good nutrition is very important. Speech and language rehab. The other thing at GBMC that I was so impressed with was they had a nurse that worked in the hospital in, I think she worked with the surgeon that did these surgeries. But anyway, she had had a laryngectomy, and she would come up and talk to the patient, and they would be so relieved because they saw someone who was functioning in everyday life, and it gave them hope. And I was just so impressed with that. So, so here's communication after laryngectomy, transesophageal voice prosthesis, and you can see where, you can see right here, stoma closure with the thumb, or you have an adjustable tracheostoma valve for hands-free operation. And the voice that comes out is very, I'm trying to think how to say it.
Is it like a robot type of voice?
Yeah, it's like a mechanical almost sound. Yeah. And sometimes it's hard to understand, but I would always say, you know, I don't hear so well. Can you repeat that? I blame it on myself. I don't want them to feel bad. So, you know, and they're fine. Some of them are just like, yeah, you probably couldn't understand me. Let me try to do that again, you know. All right, so community-based care. With these folks, when they get a laryngectomy, home care management is very important. One of the reasons for that is they have a tendency to become very depressed. Their body image is not good. They, you know, even after some saw the nurse that was, you know, still functioning in their everyday life, some people just feel like they can't go on. And it's important for a nurse to come and see them and make sure they're okay, because we don't only take care of their physical being, we also are worried about their mental health. So health teaching, how to care for their stoma, communication, and smoking cessation. Now, this is, you know, this was not funny when they told it to me, but they started laughing, so they got a smile out of me. I had somebody come in for something to do with the stoma, but I mean, it was like a year later, and they said to me, well, you know, there is some humor in this. And I looked at them and, you know, smiled a little, and they said, well, you know, when I first had the stoma, I went into the shower and forgot that it was there, and I just lifted my neck up. He said, and I almost drowned myself. So, you know, some people have, you know, a little bit of humor. I said, well, what happened? How did you? He says, I coughed a lot. So, you know, I mean, but not everybody's like that, especially women. Women have a problem with their body image. And Some guys, they just don't care. They're like, yeah, this is me. Women are not so lucky. Psychosocial preparation and healthcare resources. And when I say healthcare resources, yeah, we want to make sure that they get their medication properly, that we get, if they want that prosthesis, that they're able to get it. But the other part of that is support groups. It may help for them to be in a support group. So we want to try and, tell them about that. Okay. All right, facial trauma. So I don't know if anyone's ever taken care of a patient with any kind of facial trauma, but there are certain, they have some names. Lefort 1 is nasosmoid complex fracture, and I'm going to show you the pictures in a minute. And Lefort 2, maxillary and nasosmoid complex fracture. And Lefort 3 is a combination of 1 and 2 plus an orbital zygoma fracture, often called craniofacial disjunction. But the most important first assessment with this patient is airway. We need to protect that airway, okay? And these are the pictures of them, and you can see with the Lefort 1 right there is right under the nose. It almost looks like a mustache fracture. And if you push on that area under your nose, it's hard, okay? And then the Lefort 2 comes up, encompasses the nose, and comes down over your mouth. And then the 3 extends out to under your eyes. Now, I have an orbital fracture right here that, well, actually, I broke it. And it was because I fell in a bathroom that was all marble. And I have a plate here and 4 screws. And I can tell you that it took, well, not too long. It was maybe a month for me to recover. But I mean, it doesn't bother me anymore. But when I did have the fracture, I remember one of the things I remember was I didn't have any feeling from like the below my cheekbone to above it. All on this side of my right side of my face, there was no feeling. It eventually grew back. I have feeling now, but it takes a while for nerves to grow back. So, all right. So, what's facial trauma interventions? Airway assessment. Anticipate the need for emergency intubation. Tracheotomy. Cricothyroidectomy. A cricothyroidectomy is an incision made through the skin and the cricoid membrane to establish a patent airway during certain life-threatening situations, such as airway obstruction by a foreign body, angioedema, or massive facial trauma. And that's like right here. Okay? And debridement. It may have to be debrided. Okay? Upper airway obstruction. It could be anything. Life-threatening emergency in which an interruption in airflow through the nose, mouth, pharynx, or larynx occurs. Early recognition is essential to prevent further complications, including respiratory arrest. You have a lot of this with little kids. They need a lollipop, it comes off the stick, and it's round, and it gets lodged in the throat. Ice cubes will get lodged in the throat. I'm trying to think of what else. I mean, it could be anything. It could be a toy, whatever. I know when I was little, and I remember this, when I said ice cube, that's why I said that. I drank, I probably was about 3 or 4, but my memory of this is very, I remember it. Let's put it that way. It's very vivid. And I was choked on an ice cube. And my mom, in all her wisdom, went and got warm water. And just, she didn't know what else to do. We didn't have the Heimlich maneuver then, and it worked. It melted the ice cube, and I was okay. But, little kids always seem to have problems with choking. Or, elderly too, when they drink something or when they eat something. you know, they may not have good swallowing. You know, their muscles may not work properly. And so they may have problems with swallowing and they may choke. So upper airway obstruction interventions, assessment for cause of the obstruction, maintenance of patent airway, cricothyroidectomy, endotracheal intubation or nasotracheal intubation, or a tracheostomy. You may have to, you know, they may have to do any one of those. Neck trauma. Neck trauma may be caused by a knife, gunshot, or traumatic accident. The priority nursing care for a patient with neck trauma is assessing for and maintaining a patent airway. Assess for other injuries, including cardiovascular, respiratory, intestinal, and neurologic damage. So assess carotid artery and esophagus, and assess for cervical spinal injuries and prevent excess neck movement. Okay. Neck trauma is scary because, especially, you know, people with diving accidents, they can be paralyzed from the neck down, which can be a debilitating paralysis. So, you know, head and neck cancer history, psychosocial assessment. We're going to do a laboratory assessment and imaging assessment. Okay. Head and neck cancer, radiation therapy, chemotherapy, cordectomy, or they can do a laryngectomy. Cordectomy is when they actually remove the vocal cords. Okay. Review questions. Okay, you guys want to do these?
Yeah.
All right. 29-year-old comes into the ER with acute asthma. His respiratory rate is 44 breaths per minute, and he appears to be in acute respiratory distress. Which of the following actions should be taken immediately? Immediately. We don't want him to die.
B.
Yeah. You can do the other stuff. It doesn't mean that you won't do that, but you need to do something immediately. We don't want him to die.
Really high for a 29-year-old.
I'm sorry?
I said 44 respirators is pretty high for a 29-year-old.
It is, but if they're having an acute, you know, they're in status asthmaticus, that's not, you know, I mean, it's not unheard of.
Right.
So, everybody good with that? You understand my thinking? Okay. So, you are acting as a preceptor for a newly graduated RN, which I hope you will in the future for capstone for me, because I'm, you know, going to be contacting you. During her second week of orientation, you would assign the new RN under your supervision to provide care to which patients? And this is a select all that apply. 38-year-old with moderate persistent asthma awaiting discharge. 63-year-old with a tracheostomy needing tracheostomy care every shift. A 56-year-old lung cancer patient who has just undergone a left lower lobectomy. And a 49-year-old just admitted with a new diagnosis of esophageal cancer.
I would say A and B.
Yeah. Yeah, you could assign the 49-year-old if they've just been admitted, they're not intubated, but A and B definitely is, you know, good answer. Okay. So you are responsible for the care of a post-operative patient with a thoracotomy. The patient has been given a nursing diagnosis of activity intolerance. Which action should you delegate to the nursing assistant? Now let's think back to delegation in leadership. Let's look at these words.
I would say
D.
Yeah, I would say D.
Right, exactly. Why would instructing the patient not be correct? They're not supposed to instruct people. They're not supposed to teach, right?
Right.
Because the LPNs, technically on paper, are not supposed to teach either. But I know they do, and that's fine. Encouraging, monitoring, and recording nutritional intake, no. And monitoring cardiorespiratory response to activity, no. So we got instructing, encouraging, monitoring, recording. Now they can record, they can put in there that they've had, they ate 1/3 of their breakfast, or, and drank, I don't know how many cc's of coffee or whatever. But the other two words in there, especially monitoring, that's something they would not do. So you understand what I'm saying here. Yeah, there are some correct parts here, but there's one incorrect, so you would not pick that, okay? Monitoring cardiorespiratory response to activity, no, okay? Planning activities for periods when the patient has the most energy. You could,
I'm a bit confused on this question just because
this is not a good question, yeah.
Yeah, aides don't plan. So like, I'm thinking of the like ad pie. I mean, I guess aides can plan the best time, like to bathe their patient or
You're right, Sarah.
to walking them. So to me, if I saw this on an exam, I would probably go with B, just because
With
the
who?
record.
You just say B?
I would choose B just because as an assistant, of course, like they record their nutritional intake. They're going to encourage their patients to eat because, I mean, the aides sit there with their patients to help feed. They're going to encourage. But the monitoring, I feel like they want to do that too. Just if a patient has like an aspiration risk, they want to monitor them while they eat.
But that's not what they're saying here. Monitoring cardiorespiratory response to activity means getting
No,
up.
for B, it's
Oh, for
encourage,
B.
monitor, and record the nutrition intake.
This is not the greatest question. I'm looking at it and it's very confusing because it says it has those words in it, instructing. Well,
Yeah.
don't really instruct. They can encourage, but do they monitor and record? They can tell the nurse what the patient eat, what they ate and drank, but I don't consider that monitoring. I guess what I'm doing is looking at it as monitoring their instead of just reporting. So it's really, this really isn't a great question, but.
I really like D, the planning activities for peers, because I feel like nursing aides do that, regardless if you use the word planning or not. They you've got 15 patients at a time. You got a patient that has, the least amount of energy. So you want to kind of in your head, in your schedule, plan to do activities for them when they feel most energetic. So let's say like some older people, they're most energetic towards the afternoon or like towards lunchtime. So I would do their bath before lunch and feed them, and then that kind of stuff. That's why I would pick D.
Yeah.
Because the word planning, I mean, everybody's planning regardless of your position. And it's just kind of, that's like time management for me is how I see it. And I feel like nurses aides should be able to time manage.
So who goes with B? Say I.
I really don't know.
Oh, Sarah.
Between B and D.
How about B?
Oh, yeah.
I pick D for planning.
As in David, me too.
Yeah, but do you understand what they're saying, Sarah?
No, I completely understand. I think I'm just overthinking it because
These are not good answers. They really aren't. I put it
as D, yeah, like as an aide, you do want to plan activities for periods when they have the most energy, such as showering, getting up. I'm in class.
Who's that? Your husband? It's okay. So planning activities, if it just said planning activities for periods when the patient is most alert, but when they put that has the most energy, that gets a little confusing. But I still agree that D is, and I understand what Victoria said too. And
Yeah.
okay,
I definitely feel like it's one of those things where you have to pick the best answer.
it's true.
And like it makes no sense for a nursing aide to plan her shift for when her patients have the most energy versus encouraging nutritional intake. Like that's where I'm coming from, and that's where I picked D from, because I'm like, monitoring starts to get iffy with me with nursing assistants.
Mm-hmm. Yeah, exactly. So it is D, but I encourage you guys to talk it out while we're here, and that way you can kind of understand what the rationale is and why it was picked. Okay. And Sarah, tell him to behave himself.
I agree with Dee now, just because I went back and read the question. The patient has a nursing diagnosis of activity intolerance. So now that I went back and read the question, I do agree with D.
Yeah, I think it is D. Okay, let's go. All right, you are supervising a nursing student who's providing care for a thoracotomy patient with a chest tube. Okay. What finding would you clearly instruct the nursing student to notify you about immediately?
Continuous bubbling in the water field.
Correct. You guys have been studying. That's great. Okay. All right, so here's a rationale. And I just I took it out of the PowerPoint. So the continuous bubbling indicates an air leak that must be identified. Okay, with a physician's order, you can apply a padded clamp to the drainage tubing close to the occlusive dressing, and then you work your way down. Okay, if you clamp it there and it's still bubbling, okay, that means that the leakage is further down. So then you clamp it again. And that, when I say further down, I mean that it is closer to the chest tube. What would you call that?
Like the insertion site?
No, the actual chest tube. The I can't think of the word, but the actual chest tube thing that we record the fluids on and the suction. Okay. So if the bubbling stops, the air leak may be present at the tube insertion if you clamp it there, which will require you to notify the physician. If the air bubbling does not stop when you apply the padded clamp, the air leak is between the clamp and the drainage system. And you must assess the system carefully to locate the leak. Chest tube drainage of 10 to 15 milliliters per hour is acceptable. Chest tube dressings are not changed daily, but may be reinforced. And the patient's complaints of pain need to be assessed and treated. This is important, but is not as urgent as investigating a chest tube leak. So what you're going to do is you're going to go down that tube, and once it stops bubbling, then you know, okay, this is, I found the leak. So if it's below the insertion site, then you're probably going to need to notify the doc, and they're probably going to have to come and change out the tubing. So try not to do that. Try not to get, and sometimes patients move around so much, or, another thing that can happen is the actual drainage container can get a crack in it. So, you want to be careful of that. You may just have to change that out. But it's an it's an investigation sort of thing. You know, you're not going to know right away exactly where it is. Okay. So a patient with acute respiratory distress syndrome, or ARDS, is receiving oxygen by a non-rebreather mask. Okay, it's a face mask, okay? But ulterior blood gas measurements still show poor oxygenation. As the nurse responsible for this patient's care, you would anticipate a physician's order for what action? That's the one thing that we cannot do. Even if,
You can't intubate.
huh? What'd you say? You cannot intubate. You're right, Victoria. It's A. We can, if they say do continuous positive airway pressure, we can call respiratory and we can get everything set up. And yeah, we can do that. We can administer furosemide 100 milligrams IV push if we're given the order. And we can call a code for respiratory arrest. But under no circumstances can we perform, we cannot do endotracheal intubation.
Right.
In the hospital. So, all right, everybody clear on that? Okay. Okay, this one's interesting. Tom is a 40-year-old man who is 5'7" and weighs 340 pounds. He's a big guy. He is scheduled for a colonoscopy due to recent rectal bleeding and arrives to the endoscopy unit with his wife. He has a history of smoking 1 pack of cigarettes per day, which means he probably smokes more than that. And he has been recently diagnosed with diabetes, asthma, and sleep apnea. This guy's a mess. God, he's 40 years old. Vital signs on admission are BP 170/90, heart rate 95, respiratory rate 24, and SaO2 98%. I'm surprised at that.
Right.
That SaO2. During his pre-procedure assessment, the nurse notes that Tom is most at risk for, well, what's he most at risk for? And this, we'll do select all that apply.
B.
B and D.
Mm-hmm. Anything else?
He would be at risk for the hyperglycemia too.
Right.
Right.
What happened? Why, Amber?
With everything going on in surgery
Uh-huh.
and taking into account any meds that he can get with it, his weight, like it's all a mess.
Yeah. I mean, it can increase their blood sugar. I've seen patients come in for pre-op. They haven't eaten since, like 8 o'clock the night before. Of course, they don't take their insulin because we would rather have them high than we would low. But they come in and their blood sugar is like 450, 500.
Oh my God.
Yeah. And so you have to be really careful with them, and they're probably not going to have surgery that day. But yeah, he's really at risk for hyperglycemia. He's also at risk for low hemoglobin. Don't you think? He's had recent.
That's what I was gonna say. Yeah.
Yeah. So it's really all 4 of them. This is one of those questions that, and I don't give those kind of
Pick the best one. It's
Right?
the best one kind of scenario.
No, I should have picked select all that. I should have said select all that apply because he's at risk for all of them.
For the low hemoglobin, is he most at risk for that because of the smoking, the 1 pack of cigarettes per day, and the obesity and whatnot?
Low hemoglobin? Is that what you
Yeah.
said?
Yeah.
The
Well,
rectal bleeding.
Yeah,
Right.
rectal bleeding, but what do we always talk about?
ABCs.
ABCs.
Mm-hmm.
If we really wanted to say what is the most important thing, what would it be?
Difficult airway.
Yeah.
Yeah.
With intubation.
Because he's very heavy. He's 5'7" and he's 340 pounds. His neck is probably like this big, and a lot of adipose tissue around his neck. Okay, so yeah, he would be I would want to do his colonoscopy or have his colonoscopy done in an OR.
Would his oxygen saturation be lower if he had low hemoglobin though?
It would be, yeah. But we are concerned with the right now.
Right.
Yeah.
Right.
So it's a difficult airway.
Right.
But you're right on target. You are right.
I have a question for
Huh?
a question.
Yeah.
real quick, please. So if a patient is on NPO because he's gonna have a surgery, let's say the next day, so is he gonna be off of his insulin or diabetes medication because of the surgery? Is that what it is?
It all depends on the patient, but more than likely, yes. Why? We don't want them to go too
You
low.
said that if the patient, I'm sorry.
If they can go higher,
Mhm.
we don't know that. We don't know that's what's going to happen. And a lot of times, diabetic patients will come in and, you know, they're like maybe 250 if they're, you know, under a lot of stress. It's the ones that are kind of like brittle diabetics or, you know, they're just not controlled well that are going to be really high. Now, there are some patients I've seen who have been told to take their regular insulin, but or not take take their NPH, but not their regular insulin. So, you know, it all depends on the patient themselves. But this guy is really at risk for hyperglycemia.
Okay.
Does that make sense, guys?
Yes. Yes.
Yeah.
So the answer was what, B?
Yeah.
Right. Okay.
Yeah. Yeah. But he's at risk for all of them, but
Right.
B is the best. Okay? All right. So during the procedure, Tom begins to snore loudly, and his oxygen saturation level drops from his admission level of 98% to 89%. And the nurse administering the sedation should immediately, what should she immediately do, or he? Now, there's probably going to be simultaneous action in there, but what should the nurse who is responsible for giving this patient the medication and monitoring him, what should they do? Let's go over this. B, exactly. It's B. Why? Okay, you're going to have to call a code eventually, right? Somebody's going to have to do a perform chin tilt or jaw thrust to open the airway. They're going to have to stop the colonoscopy, but that is not going to help in reversing the anesthesia, the sedation that's been given. Does that make sense?
Yeah. Oh, because that's an antidote medication.
Yeah. Okay. Yeah.
I skipped that part of the sedation should, administering the sedation should immediately. I skipped that part of the question.
Yeah. You have to, you know, look at the total question. What are they asking me? And then you have to look and say, okay, the nurse administered sedation. What should he or she do immediately? What is going to reverse this patient's, what's happening to this patient? The only thing that would reverse it would be giving him the antidote.
Right.
Okay? All right. You would do all that other stuff as a support, but you have to give the anecdote. Okay?
Yes.
Does that make sense? Does that help you learning how to answer these questions?
Yeah.
Because that's real important to know. Okay, during the procedure, we're not done with Tom yet. During the procedure, Tom's oxygen saturation continues to drop to 85% with no patient response to stimulation. The nurse immediately should
D.
and it should be administer flumazenil should be first and then notify the physician. But like I said, you're not the only person in the room when they're doing this. You see, when I did it was myself, the tech, and the doc. So the tech can, you know, be doing stuff too, and the doctor. Okay. Always know when you are giving a sedative where they keep the antidote. Okay, I mean, I knew, but I'm saying, just like I tell you, and I told you when we were in lab with Lori, you go on, if you go on a floor that you're not familiar with, know where the crash cart is. That is your first priority. You're trying to keep these patients alive, okay? Ask them where it is. Sometimes they're in this little alcove or whatever, so you need to know where it is, okay? All right, you okay with that, guys?
Yeah.
Next. Oh, we're not done with Tom. Which of the following is not a true statement about Tom's care? His pre-admission vital signs are within normal range for a man his age with his medical history. Is that true?
No.
True. He should have a glucose test to measure glucose before the procedure.
Absolutely.
Mhm. He should have the head of the bed elevated to assist with chest expansion.
Absolutely.
Yes.
Yeah. A responsible adult must be available to drive Tom home if he is discharged to home.
Yes.
Yeah.
Because he's received some kind of anesthesia. This is a select all. I just forgot to put it in there. But what does the question ask?
Not
Not true. Yeah.
Not. So which is not true?
A.
Hey,
that one made me laugh.
yeah, I know. I heard, was that you? Yeah, or Victoria? Yeah.
Yeah.
Yeah, he's not a normal guy. Okay. Okay, so I think we're done with Tom. Which of the following interventions would be used for the patient with ventilator-associated pneumonia?
Isn't it administer prophylactic antibiotics?
No.
No.
What do we say about antibiotics? Should they be given prophylactically
Well,
now?
no, because it can create resistance.
Right. What about turn the patient from side to side every 4 hours?
Shouldn't it be two?
It should
Every should be 2, right. Change the ventilator circuits daily. Do we do that?
No.
No.
What about elevate the head of the bed by 30 to 45 degrees?
I liked
Yeah.
that one, but I chose the antibiotics, but you're right.
Yeah, we try not to give them, well, we don't give them prophylactic antibiotics because then they're predisposed to superbugs. And
Right.
then we're either giving them stronger antibiotics or none of them are working.
Right. I was thinking about treating them with like empirical therapy, but that's after they've already been diagnosed with pneumonia, not prophylactically.
Yeah. That's good, Victoria. You picked up something from the lecture yesterday, but we would only do that after we get back the
cultures.
Yeah. Mm-hmm.
How often do you change the ventilator circuits?
We don't.
Oh, you don't?
We don't. That's a respiratory thing.
Okay.
Respiratory therapy. Yeah. And keep calm and you will finish nursing school. Yay! Hey, you're almost done your first week.
I know, I can't even believe
Yes,
it.
class. Huh?
I can't even believe it.
I know.
I know, it's coming up, guys. I'm going to be graduating
Woohoo.
in a COVID world. Tell you.
Hey, I have a question.
What's that?
Can you tell me again what the answer was to the question on slide 222?
Who is
It
that?
was about a patient with acute respiratory distress syndrome.
Amen. This one here?
Yeah,
Who am I talking with?
Hannah. Sorry.
No,
My
it's
mom needed my computer, so I had to be on my phone today.
okay. Patient with an acute respiratory distress syndrome, ARDS, is receiving oxygen by a non-rebreather face mask, but the arterial blood gas measurements still show poor oxygenation, which is true. You can throw as much oxygen at them, turning it up, but this is external, okay? As the nurse responsible for this patient's care, you would anticipate a physician's order for what action? Which one did you pick, Hannah?
I didn't really pick any of them. Did you say it was A?
Mm-hmm.
Okay,
Yeah.
because I was confused on, so this is what the physician would order, but like we wouldn't do that,
No.
right? No. Okay. So because I was confused because the question wasn't asking like what we couldn't do. So would we just be anticipating them to order that for them to do it themselves kind of thing?
And as the
Okay.
nurse, you would get everything together, Hannah. You would get
Okay.
endotracheal tube, you would get the intubation kit, everything that they need, and have it ready when they come in the room so they can quick do the intubation.
All right. Thank you.
You're welcome. Are we good?
Gina, I have a question, Gina. What are the ABGs? Is it 50 is a normal or greater than 60? No greater than 60 for an ABG? What's the value?
Wait a minute, what part of the ABG are you talking about? The pH, the PaCO2, the...
Well, both of those, the CO2 and the O2.
We're going to
What's
get...
the value?
We're going
we haven't got to it yet?
No, we haven't gotten to that yet.
Okay, okay, cool. I thought I missed it in the beginning.
No, no, it's okay. You can ask. The pH is the blood, and the pH is what determines whether they're acidotic or alkalotic. And it's 7.35 to 7.45. That's the norm. But the average is 7.40. So if you go towards 7.35, that means you're moving towards acidosis. If you go towards 7.45, that means that the patient is moving towards alkalosis. Right? Yeah, and then the others, the PaCO2, and this is the nice part about PaCO2 and pH. The PaCO2, of course, is the respiratory, and that's retention of CO2. It's 35 to 45. So the pH is 7.35 to 7.45, and the PaCO2 is 35 to 45. That's kind of,
okay.
Yeah,
That's
helps
easy to remember.
Yeah.
Yeah.
Now, HCO3, which is bicarb, and that is the renals, the kidneys, that is 22 to 26. Okay, with 22 being acidotic, moving towards acidosis, and the 26 moving towards alkalosis. So we're gonna go over this. I love teaching ABGs, and I love critical care, but yeah. So make sure you read up on that, okay? And we'll go over that on Monday, because if you have a background, it'll help you.
Mm-hmm. That helped a lot. Okay.
Yeah. Is everybody?
All right, I think I'm good on that question I asked earlier. The balloon part kind of helped put it in context,
okay.
so I think I'm okay with that.
Yeah, I have a balloon here. You want to blow it up? No. when we're in class, I do demonstrate with the balloon.
Okay, yeah, that helped.
It cuts it. You know, when people come to class, they're like, you know, they're all tight and everything. And sometimes when you do stuff like that, it kind of breaks the ice and helps them relax a little bit.
Yeah, which is a lot. All right, thank you.
You're welcome. You guys are awesome.
You too, Professor. Thank you.
I just, you know, I learned so much from my students. I really do. And when I stop learning, it's time to stop teaching. So you guys have a great look. If you need me for anything, you know, I usually get back to you. If it's, listen, I need to tell you this. If it's a burning issue, please text me. Okay. I'm not always on email. Sometimes I'm working on a computer like I was last night with, you know, going over the math exam and trying to make that, you know, so that you can take it tomorrow. But I always have my cell phone with me.
What's your number?
410 913 6401.
Okay. Then we have until 4 tomorrow?
No, it's from 10 to 12.
Oh no, I have my capstone tomorrow.
Okay.
I thought I was until.
No, it's, but you know what I'm gonna do? I'm just gonna leave it open, guys.
Okay, thank you.
I'll open it up. Just don't be giving each other the answers.
Well, I'll be at work.
Promise me?
Yep.
I'm just kidding. I'm just kidding. Yeah, I will open it up at 7. And how about if I close it at 4? Or what's that?
I'm there all day. I'm there from 7 until, let me see,
I'll just open it up.
7 until 6:30.
Okay. I will keep it open until 9 o'clock tomorrow night.
Okay, perfect. Thank you so much.
I don't have to proctor that.
Okay.
It's when I have to proctor stuff that I don't want to be proctoring all day. It's just, you know. Okay?
All right, thank you.
Great, you awesome students. I will see you. Monday is lecture.
Okay.
Hey, Gina, I'm sorry I came in late today. I didn't realize we had class because I saw it was just Monday, Tuesday.
No, that's it's on the schedule, isn't it? Wednesday?
Yeah, but in the email it said Zoom on Mondays and Tuesdays. So
I'm sorry.
and it is on the schedule, but I didn't know. I thought it was just on our own, but
I'm sorry.
that's okay. I came in halfway because Claudia texted me and she was
That's okay.
so messed up.
Sounds like you were still missed, so.
We're pouring concrete in the patio out back, so that's why.
Oh, okay. Yeah, well, they tend to miss us, so, you know. I mean,
yeah.
I know mine does. All right.
Professor, I just want to know, I was kind of late too. So are you going to post this on D2L, this whole?
I am, but here's the thing with me and D2L. I am always afraid that I'm going to miss it, to do something that I shouldn't be doing to it. And I usually wait for my husband to come home and do it, help me.
Okay.
Yeah, because I don't do this. Because we have a lot of good discussions.
Yeah.
When you know I'm lecturing, so I think that it really will benefit the other students.
Yeah.
So, you know, I don't want to lose that. Okay.
When are you?
Wait a minute. What?
When are you going to post the exam review? Because we're done with respiratory, right?
We're done with respiratory, but we still have to do ABGs.
Oh, okay.
I will probably do it over the weekend.
Okay.
See, I think I explained it to you before.
You
what
did.
happened. Yeah, and I don't want that to happen to you guys. I don't.
Right.
I think it's not good for you. It's not for your benefit that way. Yeah, you're going to pass the class, and that's wonderful, and it is. But I want you to pass that NCLEX too.
Mm-hmm.
Gina, are you doing the ATI practice exam tomorrow or today?
No, Kelly, I think I sent down an email this morning. You may not have gotten a chance to look at it, but I opened it up this morning, and you can go ahead and take it whenever.
Okay, thank you.
It's hard when you guys do your capstones. It's hard on you, but you know, I'm trying to think of, you know, can I do it this way? No, because they're all on different schedules. It's different when you're in Med-Surg 2, Med-Surg 1, you have a set day for clinicals. So not for mine, no. Okay.
Could I ask you a quick question?
Of course.
Did you get my entire set of paperwork for Frederick Memorial?
I did.
Okay, good.
Yeah, I'm waiting. I put a email out to the person that I deal with over there, and they should be getting back to me. He has to correct those tests.
Gotcha, thank you. Yeah, because like my email's been messing up the past like week or so, and I was so scared that it never came through.
No, I thought I try to get back to you. I try to say, yeah, I got it or something like that, but maybe I missed doing that for you. I'm sorry.
Honestly, I probably didn't get it. I won't even lie.
Okay.
Thank
I
you
have
so
a
much.
question.
What's up, Ange?
I haven't done the proctor track, so how does that work on my end?
Well, I'm not sure. I have to find out too. I have to work with somebody and figure out how to do this. It's not the easiest. It's not user friendly, in my opinion. And we'll just have to see. I wish they could open up the testing center, at least for the nursing students, because, you know, this is my take on this. You guys are going to be taking high stakes tests. Your testing has to be, you know, right on target. Whereas English, yeah, it's important. I'm not saying it's not, because it is, but it's different. You know, that being said, I'll get off my soapbox and, and, you know, I will look at Proctor Track and I will let you know.
Okay. Thank
Right.
you.
Tell the pups I said hi.
Yes. Have a good day.
You're welcome. So, anything else, guys?
No, thank you, Professor. You have a great day.
You
See you on
too.
Monday.
Thank you.
All right. Thank you.
Thank you so much.
You're welcome. How do I get out of here?
Hey, Gina, I had just one question about capstone.
What's that, hon?
I was just wondering, so you gave me who my person would be, and I just emailed her to I'm at Frederick, and you said because I just need to get a ID badge, like a student badge, and I didn't have to worry about doing all that paperwork since I'm already like employed, right?
Yeah.
Okay, perfect. So I just emailed her, and I probably emailed her like probably like 3 or 4 days ago, just to make my schedule and everything, and I haven't heard back anything, so I didn't know if I should maybe send her just a follow-up email again and just see, or
I would. And
okay,
if she doesn't get back to you, let me know, and I
okay,
will talk to Mark Smith.
okay. And I didn't know because I know it's like her hospital email, so I didn't know if maybe it came in differently, maybe went into her junk thing, just since it's not like protected, you know.
Sometimes they get so busy they don't check their email.
Yeah,
when
that's
they're
true.
not
And I know how I am about work. I don't check my work email often
Yeah.
either.
Yeah.
Okay.
So maybe we just make a call to the unit and
Yeah.
you know, ask if she's working. You
Okay.
know, can I speak to her? And if they say, you know, just say, well, I'm her capstone student and I'm trying to get in touch with her.
Yeah. Okay. I'll do that then. Thank you. I appreciate
You're
it.
welcome. No
All right.
problem.
You have a great day. Bye.
You too. Let's see. Okay.